Panel. Welcome to all and in the room and to those who are joining us online. Just to note that we normally say that this meeting is being recorded by the Council for live and subsequent broadcast by the Council's internet site. By entering this room and participating, you're agreeing to be recorded and filmed for this purpose. Any apologies for absence, Dominic?
Yes, apologies received from Councillor Ian Curran.
Okay, thank you. Any items for urgent business? Declarations of interest. I was mentioned that my sister's GP in Tottenham and I'm a member of the LCN. Anybody else? Anything? No? Looking. No. Okay. Any deputations, petitions? No. Okay. So we're going to do the first agenda item, which is the minutes, which is on pages 1 to 12. So we approved the minutes of the previous meeting. That was the budget meeting. So I'm just going to ask my fellow councillors and co-optee members, committee members, if they've got anything around the minutes they would like to. No. Okay. Just to mention that on the minutes, there's a tracker that's just been circulated so that people can see what has been added to and completed since we last had our meeting. One thing on the minutes I would mention, which was the budget, is just to highlight that as a committee and went to OSC and to Cabinet, that we requested a meeting to be started reasonably soon around the finance, about how the paper's being presented for future. Just because I think we had some issues this time with people that were not councillors probably and maybe weren't quite as au fait with the financing, about how we make sure that information is easily available and everyone is very clear what we're scrutinising. So I think we had an understanding we'd be starting that sooner rather than later, because I know it gets really busy from September onwards. So pre-September would be really helpful if that's available. Thank you. So the rest of the minutes everyone's happy with? Okay, I'll take that as accepted. So we're going to move straight on to our first agenda item, which is on the winter systems resilience, which is on pages 13 to 26. If you'd like to turn to the but yeah, agenda item 7. So I've got Vicky, who is on screen, and I've got Rachel. But before we start, I'm just going to go around and introduce ourselves as councillors and members of the panel, and then I'll ask anyone who is either on Teams or in the room to just introduce themselves, just that members of the public are aware of who is speaking. So I'll start. I'm Councillor Pippa Connor. I chair the Adults and Health Scrutiny Committee. That's about.
I'm Councillor Anna Abela and I represent Haringey Ward on Haringey Council.
I'm Cathy Brennan, Muswell Hill Councillor and on the committee.
I'm Nicole Clement, Councillor for Tottenham Central Ward.
Thank you. And members, I've got also Councillor Mason on tonight. Just
hi everybody. Yeah, I'm Councillor Mary Mason representing Bounds Green Ward, and I've expressed an interest in joining the panel, so I've been invited to come along tonight. Thank you.
Thank you. We've got Helena.
Hello, I'm Helena Kanya. I'm one of the co-optees on this.
And I've got Ali.
Hello, my name is Ali Amasiali. I am another co-optee on the panel.
Excellent. Thank you very much. Okay, so moving on. So I've got, I think, is it Vicky you're presenting tonight? Because your name's on the report, or am I looking to others in the room?
If I may come in, Chair, Rachel has kindly joined us to do the winter pressures, the first part of the winter resilience, and then Carl is going to do the finance of the winter funding, and I'll add where I can be of ability to offer some support to those presentations. So thank you.
Excellent. So Rachel, it's over to you. So we've got sort of a roundup by yourself and then Carl to come in. obviously we've seen the slides, so if you could just pull out highlights or anything particularly you really want us to be focused in on, or anything new, that would be brilliant. So Rachel, over to you. Just introduce yourself. Thank you.
Thanks very much, Councillor Connett. So it's really nice to be here. I'm Rachel Lissauer. I'm the Director of Integration for Haringey, which means that I work for the Integrated Care Board, which is the CCG, as was. We are now work as an integrated care board across the 5 boroughs within North Central London, and I head up the Haringey team. So I think that the most important elements of the presentation are just the context that we were facing going into winter this year, and particularly that context insofar as it relates to North Middlesex and to Whittington Health. So one of the points that I wanted to just make clear is that within primary care, we are seeing the GPs are seeing and talking to more people than they were this time last year. So the numbers being seen in primary care and in the community are going up. The proportion that are being seen face to face is also steadily increasing, and the proportion of people who are being seen on the same day is around 50% of people who present into primary care. The context that we were facing heading into this winter is that we had an increase in ED attendances, and particularly at North Middlesex Hospital. What we weren't seeing people being admitted into hospital in vastly increased rates. It was primarily people being seen in ED for minor illness and minor attendances, but it has meant that the EDs have felt and have been extraordinarily stretched, and that's partly the context for the ambulance waiting times, and it's also partly the context for some of the reason that we have focused our winter access fund and some of the additional funding that we've had, both on putting on more primary care appointments and also on increasing our primary care presence within the ED department at North Middlesex. So we know just from being part of the national media, the national picture, sickness levels have been higher across all staff groups, so staff are working harder. And our flow has been really under pressure this winter, and that's something that Carl and Vicky will talk a lot more about. So there is a huge amount of work that we've been putting in, basically at all of our key points. So at primary care, at the point of ED attendance, and at the point of discharge back from hospital, and that's really where we've been focusing our additional discretionary winter funding and capacity. So I think maybe I will just pause there, and Carl might want to take over and talk a little bit about the Winter Access Fund and some of the ways that has been deployed. Or Carl, do you want me to do the health bits first?
I don't mind if you want to cover the health bits, and I can cover the adult social care side. Okay,
fine. So the Adult Social Care Discharge Fund is a fund that was distributed both to local authorities and to integrated care boards. So both the ICB and the local authority got a proportion of the discharge fund to deploy. The idea is that the funding had to prioritise our ability to take more people through the system, so to expedite discharges and to increase the reduce length of stay and increase the proportion of people who were coming through our discharge processes. And I just want to focus on a couple of elements of additional funding that we've put in, particularly into primary care, because they might be of interest to counsellors, and some of it has not necessarily been hugely visible, but it has made a big difference in primary care's ability to function over this winter. So we have put additional funding into GPs' ability to see children face to face. We've put additional nursing capacity in, and the GPs have also stood up a particular type of clinic, an acute respiratory infection hub, and patients where they have got primarily flu and respiratory symptoms, where primary care has not had capacity, patients have been offered appointments at the acute respiratory hubs, which have basically been in our extended hours enhanced access hubs. So they've been in existing GP practices. So that has meant that each week we have been putting on significant amount of additional primary care capacity. And I also just wanted to mention the GPs at the front door of ED, and it's the last slide in the pack. So one of the things that we did through winter last year was we put 2 GPs at the front door of the emergency department, out of a recognition that there are high numbers of people who are attending, not with minor injuries, but with minor illnesses. So exacerbations of their chronic conditions, for example, or needing medication urgently, or just wanting advice, but on something that is medical rather than something that is specifically a minor injury or a kind of acute emergency. So we have been running that from largely 8 till 8 at North Middlesex. And I think one of the things that's been really encouraging about that is that we've had very, very good utilisation. So 80% plus of the available appointment slots have been used, and that has allowed us to see something in the region of about around 200 additional patients per week within the front door of North Middlesex. So I just wanted to give a little bit of a flavour of the of some of the ways that winter access funding has been used to extend our primary care capacity. I'm really happy to take any questions on this element of the presentation, and then Carl and Vicky will talk a lot more about the way that we've deployed the discharge fund to support discharges.
Okay, thank you. That's a good place, Rachel, to stop to look at ask us some questions really around that sort of NHS side of things. So I've got Helena's hand straight up there, and then Anna.
I mean, it's great news that you have this hub, which I guess is it only for patients that normally attend North Middlesex? My question is, what's happening in the Whittington, and also how many doctors are actually using this? Because I can assure you, I know of one that isn't using it at all. And that actually puts a certain percentage of the population at a disadvantage. So maybe you could just fill me in about how that's being advertised or how they're being pushed to use it.
Yeah, these are good questions. So the GPs at the front door of North Middlesex are not being advertised to GPs. So what's happening is that if people go to ED, they receive a triage. so somebody will talk to them, and it's been quite a process having people with the right training to do, nurses with the right training and expertise and confidence to do that triage. And they will then say that whether somebody is suitable for the GPs at the front door, or for the minor injury service, or whether they need to go into the rest of the ED department. So it shouldn't be that GPs are referring people into that front door at North Middlesex. I would hope that they were aware of it, but they shouldn't be referring people into it. It is just a way of making sure it's basically reducing the pressure on the urgent treatment centre at North Middlesex, which otherwise finds it very difficult to cope with a really high volume of people with relatively minor but pressing health concerns.
Okay, thank you. But can you just tell me what's happening at the Whittington?
Yeah, so there are GPs at the front door of the Whittington, but they haven't had the Winter Access Fund made available to increase that capacity significantly over winter, because the need is lower than it is for North Middlesex.
Does that mean that they have not got an increased amount of people arriving at the ED as well?
So they have seen increases in ED attendances, but it hasn't been of the same order. And the other thing that's different about North Middlesex is that when you look at it, North Mid has a relatively high proportion of people who attend and then don't subsequently have any tests, diagnosis or admission. So they've attended purely to see a doctor, but it's not something that has warranted a diagnosis or admission. So it lends that kind of case mix, or that type of presentation lends itself much better to GPs at the front door. And that's North Mid has got a slightly different, it's got a slightly higher rate of people attending with that particular kind of mix than other hospitals, and a slightly higher proportion of working age adults and young kids who we see going to North Mid in higher numbers and a higher proportion of the ED attendances than the other trusts in North Central London.
Okay, so I suppose my last question, because I can't hog this all, is if the money were available, would it improve the service that the Whittington is offering?
It's a really good question. It's not one I think that I could answer. I think that Whittington would probably say that they have a very substantial ambulatory care service. So and that tends to work very efficiently. I think that they would probably say that their real challenge over this winter has been with getting people out and freeing up beds. And actually what we've been seeing is so I think that that's what they would say, rather than their ED their ED kind of pressures. They haven't had the same level of ED pressures quite as North Middlesex, but they have been experiencing very high bed occupancy and real challenges with getting patients out after they're medically fit to be at home. So it hasn't been hugely controversial, the fact that we put additional capacity as a system into North Middlesex and not into the Whittington.
Okay, thanks a lot, Rachel.
Thanks, Helena. Councillor Bella.
Thank you, Chair, and thank you for the presentation, Rachel. We sometimes hear public health professionals argue that promoting self-care, so empowering patients to take a driving seat in managing their own health, could reduce some of the pressures on primary care. Do you think championing this approach locally could help to reduce some of the pressures you're facing? And if so, do you see a role for Haringey Council in promoting this among residents?
So when we talk to GPs, they, I think, are really appreciative of the really significant support that can be offered by social prescribing, peer support, local area coordinators, because quite often when people come to them, particularly where they've got chronic conditions, there are people come and they bring their whole selves, and there are lots of elements that the GPs don't feel like they're best qualified to support people to manage. And obviously the kind of appointment structure in general practice, again, it's just not conducive to the real support that people very often need in helping them to kind of navigate the system. So we've got a lot of focus on building up the team in primary care, getting more pharmacists, getting more nurses, paramedics, and mental health practitioners. And so that's a real focus of energy, and GP practices have almost all of them now got a social prescriber who is assigned to their practice. So the quick answer is yes, absolutely. And I do think there's a role that public health and other professionals can really play in supporting people to both manage their own conditions, and also just can take a more holistic approach to the things that people are presenting with.
I was just wondering if you think there's more we could be doing either as a local council or across London to promote this.
Specifically supporting self-management.
Yes.
So I'd be interested in Will's opinion on this. I do think that there is, and I also think more culturally appropriate and peer-led support is really important. And I think that I mean, the answer is yes, but I think we shouldn't be just deflecting people and saying you can manage your own condition. I think it does take quite a lot to find the right ways of doing it that people really want to engage with. So we do have things like supporting self-management programs for people with long-term conditions like diabetes, cardiovascular disease, and I think that it does always feel like that's run without a lot of funding and often does deliver quite a lot of benefit. But sometimes you do find that you get better engagement from the people who are already engaged. And so we need to be better at finding ways of just being more inclusive and genuinely peer-led in the way that we in the way that those self-management kind of programs and support sessions are run, because otherwise you can offer them and you actually end up getting relatively low take-up.
I just wanted to respond as well, because I think it's a really good question actually, Anna, and I know that when I went to visit the new West Green practice, we had a really good conversation and demonstration of that. So the GPs have specialist spaces that they can use. It's obviously a new surgery, and what they're doing is convening groups of people who are exactly doing that, looking at their self-management around their diabetes, sharing their experiences. It's often culturally appropriate because they're coming together in a group and they're talking about some of the things that challenges they face within their own, it might be culturally specific diet, etc., to manage their health. So I think there's some really good examples, and I think part of it, it's not the whole story, but part of it is about these facilities where there's more space practices to convene those groups and bring together maybe the right people, I think, because I think it only works if it's, I think, a little bit facilitated. There's a little bit of online as well for some of them, online and in person. But I think that's a really good question around how we could support more of that across the borough, and some of the answer is resources and having the right spaces and tech as well to be able to enable people to do it at home or in person.
Great, thank you.
No, thank you both for your answers, and I'm glad to hear that this is happening in my ward as well.
Oh yes, that's right. I'm thinking about that dimension, but yeah.
There we are. Okay, thank you. So I've got Councillor Mason, and I'm just looking down the line if there's anyone else got anything on the NHS side. Okay, I've got a couple of questions on the NHS, and then I'm conscious we'll move to Carl to sort of get that sort of more joined up aspect to it. So Councillor Mason.
Thank you. And it's really good to hear, Rachel, of the different projects which are going on, because I think that that interlinking between community and health is essential in terms of people who are lonely, people whose diets are really poor, whose housing conditions are really poor. And we all know that those impact vastly on people's health. The question I'd really like to ask is that there is a little bit in my ward of social prescribing going on. I completely agree that one of the problems is that the social prescribers often tend to be able to build up a relationship with those who easily access those services, instead of building up the relationship with people who are perhaps new to that, and whether it would be possible to think about venues for outside of the doctor's surgery. You know, for example, there is a room in a tower block which is probably in the more deprived end of Bounds Green, and so it would be possible to do those kinds of things, but also to link up with some of the projects like food banks to make sure that we're accessing the kind of people who perhaps don't get into services except for rush to the hospital at the last minute, and they're obviously taking up space within the NHS that isn't really meeting their needs either. So that's just a thought about kind of reaching out into the communities as well. And of course, interpreters are really important if we're going to do social prescribing. Thank you.
I mean, I really do agree. I think what you're talking about is a real kind of lessons from COVID. Go to where people are, and go to where people are already accessing support. And I think it's a really useful just reminder that I will take away to think a little bit about that, just about that sort of outreach model a little bit more, because we have, I think over winter we have gone slightly the other way. We're back into much more capacity in the places that kind of people traditionally have access, like general practice and ED at the front door, and I think that there was a lot of funding last winter that was specifically for really targeted outreach in the places that people were going, and it is more resource intensive to organise things like that. But I think it is just a bit of a reminder, because we are seeing such high numbers of people going through food banks, and we had been thinking about it from a vaccination perspective over winter with flu vaccines, etc. But potentially we just need to keep on reminding ourselves for other things, health checks, social prescribing. So thank you for the point.
Okay, thank you. I've got a couple of very quick questions, and it more sort of NHS, and then obviously we'll bring Carl in. So a couple of questions I had. You said about the Winter Access Fund. Some money was to the ICB, some to the council. Do we know how much we get, and is it going to be a recurring amount, or is this a one-off fund? Obviously, because that then does have an impact on the sort of offer that we can look to sort of to do. And then on page 18, I noticed the average response time for strokes was 40 minutes, double from 2019. I think that's in relation to the ambulance. Is there anything being done specifically? I know there's a real problem at the moment around ambulance handovers, but I did note there was this, I can't remember the name of it, whereby one of the ambulance staff went into A&E and looked after the 6. So you sort of 6 people who are in ambulances are put into one room, and one ambulance paramedic looks after those 6, allowing those other ambulances to go back out again. Is anything like that happening across in our sort of area at all, to allow maybe the ambulances to be freed up a bit? Because I'm just really concerned about that. That's of times that have been mentioned on this paper. Thank you.
That was cohorting. I think it's referred to as cohorting. I think that's
Cohorting. Thank you. Dominic's reminded me the word's cohorting. It's a very odd name, but there we are. Thank you.
So there is cohorting that is happening, but I don't have a really good definitive answer of how much that's happening in North Middlesex and Whittington and what the impact has been. It was introduced relatively quickly and relatively recently, so I am also interested in finding out a bit more about that. So I will look into it, Councillor Connor, and get back to you. What was your other question?
About the money.
About the money.
Yes, and whether it was an ongoing.
So Vicky, do you want to give the figures? And it's non-recurrent, sadly.
Yeah, so the winter precious funding that comes out practically every year is government initiatives, and unfortunately the challenges that we have with winter funding is it comes the last minute, and also we're not aware of the amounts we will get until it's been given. So it is challenging, and I know that Beverly was in the room. She's been meeting frequently with the Department of Health and the ministerials to understand how we can embed that in a much more timely manner so that we can get the optimum from it. Because the challenges are that although we work together closely with the ICB on putting in some projects and plans around early implementation, getting staff in and getting things into play at a late point is quite difficult, so it's challenging. So yeah, Carl will go through the figures now for both the ICB and the local authority. Yeah, but there is challenges around it, and once he's done that bit, I'll come back in and just talk to you about the NCL programme and the successful work that we've done collectively over this winter and the outcomes that we've achieved. Thank you.
Thank you, Carl. And if you'd just like to introduce yourself to the committee, thank you.
Thank you, Chair. So my name is Carl Brownsill. I'm the midterm financial strategy lead for adult social care. So in the slide pack that was issued, so I'm just bringing up a copy here. So the section that I'll be discussing is on slide kind of 10, 11, and 12, which is mainly around the basically adult social care discharge fund. What the purpose of the funds were, how it was allocated to the ICB and the LAs. Would it be easier if I put up the slides for me to show on the screen?
Yes. Is that the additional funding discharge, which we've got as page 23?
Yeah, you might have it in a different order in your slide pack. Okay, I can bring it up on the screen if that makes it easier.
Thank you.
Yeah, that's fine.
So yeah, the additional funding, so the discharge fund. So the aim of the discharge fund was to really reduce the basically the number of discharges waiting to be discharged from hospital. So in the distribution of the two separate lots of funding, so there was a proportion allocated to the ICB and a proportion allocated to local authorities. So within Haringey, we had a set number, a figure applied or allocated to, say, staffing initiatives, so to really strengthen the workforce to enable us to deal with this additionality of cases coming out during from November kind of onwards up until current date. And then also an allocation of that went on to cover the cost of care purchasing from the additional cases. So in terms of so again with the ICB's allocation, so working closely with our colleagues in the ICB, we had a look at what the pressures were within NCL and then locally as well, and looked at best how they could be allocated, either whether it's looking at mental health discharges, or purely looking at whether it's additional pathway 2 beds, or whether it's looking at pathway 1s. So the funding prioritizes the approaches most effective for freeing up basically the maximum number of hospital beds to reduce delays within the discharge process. I'll just go on to my next slide. So as mentioned, the discharge funding has allowed kind of us as a system, so the Haringey, London Borough of Haringey and the ICB, to have a look at that additional capacity that we could take on through the delivery of this additional funding. So what I've got on the slide just there is it shows pathway 0, pathway 1, pathway 2, and pathway 3s. Dominic has kindly printed off kind of a brief description of each of those pathways, and I think those have been shared as well, because I didn't include those in the slide. But what we can see is within our kind of reablement service, the figures for October, November, and then where there's been quite a large increase for pathway 1 cases for referrals in kind of December, and that's steadily continued to January and February as well. So being able to take on the additional cases is being able to reduce the winter pressures across the system and enhance that, basically the service that the residents of Haringey are receiving. The additional 2 slides that are here, so the additional primary care capacity, which Rachel's covered already, and then also with the utilisation of primary care.
So thank you, Carl. You haven't actually mentioned any figures.
I'll do it.
Yep.
Yeah, that's to Vicky. Okay, Vicky.
Hello, everybody. Thank you very much. Thank you, Chair. So the local authority, the council, got 957k, and the ICB got just over 1 million. So basically we got an allocation of just around 200 million, and we invested that on various projects across the system, including we put some funding into a without prejudice fund, which enabled the IDTs and intermediate care teams to think really quickly around individuals and their complex needs, and sit outside what we would normally agree as a pathway to discharge people in a timely manner. For example, 24-hour care, people who may need some support or are homeless. So over this winter, we've been allowed to be really more innovative on how we discharge patients through the system. We've also secured 2 sets of accommodation. One is Ruby Ward, which is an intermediate care base that sits on one of the wards and that we share across NCL. And additionally, we've secured 5 step-down flats within Haringey that have been utilised for people who may be homeless or are just not quite ready to go home. And those have been supported with some wraparound care as well. Additionally to that, we've been successful in getting some staffing to wrap around and support those processes and those assessments coming through the system. And for the most of the funding, it's been placed within reablement, where we've been able to secure additional capacity for people to go home in a really timely manner. I'm going to share some really, for me, what is quite exciting news. Even though it feels like the pressure is significant within Haringey and we're constantly working together to achieve the right outcomes. If you look at the national data set, about 6 weeks ago, Haringey was the 7th best in the country for discharges and throughput. And I feel that every day with the low numbers that we have that are highlighted as being no criteria to reside. And that means that a person should be transferred from the hospital to the best setting as quickly as possible. So that's really positive for Haringey. We do have small numbers. We are in the top quartile nationally, and we do get to use and talk to our partners in the system on what would be the best opportunity to utilise this funding to get people out as quickly as possible. Like I said earlier, the challenges are that the funding comes quite late in the year, which means we're scrabbling around, we're fighting the system and our partners across NCL for staffing. There's some more work that we're doing as well. Across NCL, we've been working with Empower, which is a company that the ICB and the councils have brought in to support us in our next steps and direction for our discharge to assess for next year. So I know you've got the pathway 0 to 3 in front of you. They've really focused down on that pathway 1, and what that has brought to our attention, and I know Beverly's been singing this song for quite some time, is that Haringey does have a little bit of not as community support as across the other NCL boroughs. So we are lacking in that even amount of services, particularly around that physio and therapy support for people to be discharged. However, Empower's coming. We've got a fantastic document. We're meeting tomorrow to do a summit around our intermediate care reablement offer. There's further work happening this month, and we've got that agreement that we're going to level up in Haringey across the NCL patch to ensure that our residents are getting the support and the care that they need. So that's a really important piece, and it's, you know, it's the fight for actually people getting what they need to be discharged. So I can bring something back on that in a couple of months if anybody's interested in our next step on that levelling up and looking at what our community services offer is.
Okay, thank you. That's really helpful. I've got now a couple of questions. I had Councillor Peacock and then Councillor Poku. I'm just checking. I've got Councillor Mason and Helena. Ali, did you have a question about virtual wards? Possibly. Just seeing if I've remembered correctly. I will come back if that's the case. So we'll start with Councillor Peacock.
Thank you very much. I'm very, very concerned about the discharge from hospital. I had to contact Vicky on more than one occasion for this one gentleman who was asked to leave UCH, and he was really distraught about it. And she managed to get him a few more days there. But after he got home, he was still constantly phoning up, constantly in problems, constantly calling out ambulances for the next few days, because he was very concerned that he'd had half his lung taken away, and he was very concerned about that. So I'm really worried about that. And I'd like to know how many visits are made to people recovering at home or in residential care. You know, what's it, you know, is it once a week, once a day? How often do the nurses or whoever come and check on people? The other thing is, where are the step down places? Are they all in sheltered housing? Because I did bring this up at a previous meeting. And I know that we had a step down place at the Lindales, and I think there's also another sheltered accommodation. So I'd like to know how many, if you don't mind, please.
Okay, thank you. Vicky? Or...
I'm happy to come in that. Thank you, Chair, if you want me to come back in on that. So community services are set to provide to the level that a person's needs are. So I do know that particular case that Councillor Peacock is discussing, and we can't go into any detail. However, I did manage to step in and support the system and also support the community work as well. And I think sometimes people have issues that are outside of that pathway 1 that we need to be mindful of and step in at an earlier stage to support those individuals. When we're talking about the step down beds, we have got quite a large collection across NCL, and with the new agreement under pathway 2, so that's step down from hospital, people can access, Haringey residents can access any of them. So we've got collectively, we've got Ruby Ward, we've got Cape Town, we've got, and I'm going to ask Rachel to step in, but we've got quite a few.
Yeah, we've got and they're in different places. So our patients in Haringey, the first port of call usually for step down is in Priscilla Wakefield. We've got some beds within Priscilla Wakefield that have MDT, sort of multi-agency input, and that are more for short stay. But then there are 2 places in Enfield. There's Canterbury Ward. Cape Town, that are both on the Chase Farm site. There's also some beds in Islington and Camden. There are beds in King's Cross and at Mildmay. So the very useful thing about working on a North Central London footprint is that if somebody is needing a step down bed, then there is a kind of little team that look across the whole of North Central London and can identify and place somebody in any of those step down beds.
Thanks.
I'm actually not talking about those people because they've got constant care. I'm talking about the people that are put into sheltered housing. And often I get the complaint they've been put into shelter house, into a flat, into a shelter housing block without any food, without any of the essentials. And then I have to try and sort that out. So that's what I'm concerned about. If you put in people into like the Lindales, yeah, or Campbell Court, they need the support. They need that when they get there. They need to have the food because they can't go out and do the shopping. They need somebody to be a carer to look after them.
So I've got Vicky to come back in on that. Thank you, Vicky.
Thank you, Chair. So if there is individuals that's discharged from hospital into step down flats, and we have just purchased another 5, we do have that facility. We do also have wraparound care that can do shopping, that can go and collect things, that can provide care and support throughout the day. If it's outside of that, Councillor Peacock, I'd be more than happy outside the meeting to have a conversation and let's pick it up from there, because I'm more than happy to go and to work with you on improving that service.
Thank you.
Just to mention, we did do a scrutiny and we had a look at wraparound care quite a number of years ago now. My understanding that it did seem like a very good service. Somebody came back as soon as the person was discharged. So can I just check, is that a well-funded and up and running? I mean, because often services that do well sometimes can get cut. So I'm just checking, is that service still sort of as well funded and as effective as it was when we looked at it quite a number of years ago? Vicky.
Thank you, Chair. So I would say that it's grown, developed and improved significantly, because not only do we provide wraparound care for people going home from hospital with personal care, meals and medication, but we also can do things outside of what we would normally do. So, for example, Age UK will be sat in a hospital, they can go and get shopping, they can collect a key, they can take a person home, put the heating on. There's lots of things that we can do. There is also some initiatives that have set up in North Mid around direct payments from ED and from the discharge lounge, where if an individual is about to be transferred home and they feel that they need something quite quickly, whether it be, in this instance, it was a lamp, it might be a quilt, they were really worried about not having a pair of curtains or something, they have now got the ability to have the cash and go and buy that item for that individual as well, including shopping and other things. So for me, that's gone to a place of excellence comparatively to where we were a few years ago. Thank you.
Here, so thank you. I won't spend any more time on that, though I could, because that's really interesting. But Councillor Poku, then I did say Councillor Mason, and I've got Councillor Brennan.
Helena, I think.
Oh, and Helena, sorry, Helena was in there as well before, I think. Sorry, Kathy.
So thank you for that. So just first of all, just well done for being in the top 7 and also in the quartile of the country. That's good work. But my question is related to the funding that you received for the boroughs. Just want to know, how does it compare with the funding for the other boroughs in NCL?
Thank you. Do you want to take a couple of questions, actually? Because I know time is going on rather quickly. So I've got Helena and Councillor Mason and Councillor Brennan.
Hi. Hi, Vicky. You might be able to answer this. Discharge to assess. I'm quite worried about the lag between the discharge and the assessment, because there were times where it was quite long and people needed a lot of help. I wonder if you could give me some indication whether that's still a problem or whether the assessment comes within a week or less of that person coming home.
Okay, thank you. Councillor Mason.
Yeah, I just wanted to, it is picking up on the discussion that was introduced by Councillor Peacock, but I'm involved with Browns Green Food Bank, and we run an advice service, and I've had 2 people over the last couple of weeks who have been discharged, and they were discharged to housing, homelessness, and they were put somewhere without any access to their benefits, or the room that they were put in didn't have basic utilities. And I'm really glad to hear, Vicky, that that generally doesn't happen. But of course, there's always a few people who go through that slip through the net. And maybe, I don't know whether they discharged themselves or what, but they didn't. They came to us completely destitute with no food and nothing. So, and it's not just one person. So I just would like to know what the route is for when we do pick up on those people, how we can then bring them back into the system and make sure that they have access to resources.
Okay, Vicky, if you take those, or Rachel, if you take those first 3 questions, and then we'll go to Councillor Brennan. Thank you.
Thank you. Thank you, Chair. So the NCL funding is been given based on population and throughput. So there is a slight difference in the boroughs across NCL on their funding pots, and you would expect them so. So if a place has got a higher population, they're going to get a higher proportion of funding. So the answer to that is yes. However, we are in discussions to try and get a little piece more of the pie, myself, Beverly and Rachel, for Haringey, specifically because of the enormity of challenge that we've had this year. So discharge to assess and the lags. So discharge to assess and the lag between somebody discharging and a social care assessment has been pretty challenging for us this winter, and I'm sure that for previous winters as well. And the rationale behind that is our Pathway 1 service under reablement is met by the local authority at this time, and people discharge, and because the enormity of challenges that we've had in throughput, so higher demand and acuity has meant that people have sat on reablement longer than they would normally sit on there because of that throughput. So we're getting as many people out back to their homes where they want to be as quickly as possible. So it has stalled us a little bit in the middle. However, from a positive perspective, we are now, there is 2 people as of today that's been on there longer than 6 weeks. So we've started to work on a workforce strategy. So about 2-3 weeks ago, we implemented, previously been working on it for a while, a social work officer role that we've been training up to work with our reablement team to review individuals with a vision of coming off the service or going on to longer term care. They've been in place for around 3 weeks now. They're working really positively with individuals. So we are seeing that transfer and getting people off before the 6-week process. It's my ambition by the end of March that everybody is reviewed within 2 to 3 weeks and then reviewed again at that 6-week point should they need ongoing reablement, because sometimes 6 weeks isn't enough for individuals for us to get them to their optimum before deciding what their next place of care or support is. So that's a really positive step, and the workforce strategy has been in place, and we've also encompassed that within adult social care to move on with our reviews in other areas of work. So hopefully we'll be in a much better position for the next financial year and better prepared for next winter when we get the influx. And just for Scrutiny's assurance, the people that we've brought through this winter, we've gone up as high as 298 in 1 month. The normal levels are 226, sometimes a bit under, but we have seen that higher level of referrals coming through. The flip side of that is we've gone from 27% of patients coming through reablement needing longer term care rise to 49%. So we are seeing more levels of demand, more levels of acuity. So that's the reason why sometimes we may not meet that 6-week assessment point as quickly as we can, but we're on a better journey. So thank you for that question. And my last question was around food banks and housing. There is a discharge to assess process for Pathway 0 that sits within North Mid and within Whittingham. It is run by a specialist person that we've funded through the winter funds to discharge people to housing. if there is a disconnect, we can connect people back in straight away to connected communities and other areas. And I'd really like to pick a conversation up with you, Councillor Mason, at the end of this session, so that I can ensure that, one, that we meet the needs of those individuals, and secondly, that that doesn't happen again.
Thank you.
Thank you. Thank you.
Okay, thank you. Councillor Brennan.
I mean, my question's partly been answered. I'm just thinking of the situation, this is again for discharge to assess. When I've had somebody discharged, I just had an operation for cancer, she had a brain tumour, and she was discharged to assess, and she was just there, and she was very vulnerable. Now, I wrote, and we got assessment, came in very, very quickly. We're not talking about 6 weeks, you're talking about few days, almost the same day. But is that the norm? Is there an assurance that when people are as vulnerable as that particular person was, can we be sure that they do get assessed very quickly so you get the support in place? Because, I mean, it did work that time, and it would work in hospital, of course, but you could fall in through the net, I think, if you're at home like this.
Okay, are you able to take that up, or was that a Rachel question?
I'm happy to take that up, Rachel, if that's so for individuals that are being discharged, especially with complex needs, they will be discharged with the care and support and wraparound services how they are presenting at the ward on that day. So it might be that that individual might have presented slightly better, and then on discharge there may have been a lower level of ability. So that's all I can think about for that individual case. That people are assessed before they leave hospital. They can be assessed by their OTs, physiotherapists, IDTs, Age UK. So every step you see from 3 down, they will be assessed on their requirements against those pathways. Secondly to that, if somebody does discharge and their level of need hasn't quite been captured correctly, or it's reduced on discharge because of the enormity of going home for an individual, we have a rapid response service that immediately responds and can provide that wraparound care to every resident within Haringey, and that's up to 4 times a day and sometimes night sitters. And we also have services within Priscilla Wakefield where we can step people up if at home is not safe for an individual. So there is lots of things that we can do within the community to ensure that residents, once discharged with or without care, are safe and get their needs met.
Councillor Brennan.
Yeah, it feels that the particular case I'm thinking of, she was told in advance she was going to be discharged to assess. She sent messages to loads of people saying, I don't feel safe, because, you know, she had an operation for a brain tumour. And this came to me as a councillor, so I contacted the council. She was assessed by the occupational therapist and such after she'd left, because she'd been discharged to assess. So the assessment did happen quickly, but it sounded and it felt for her not very safe, you know, to have done it that way round. And it seems like that was, obviously it was done to free the bed, but it sounded dangerous.
Okay, I've got Rachel who'd like to come in on that point. Rachel.
So I just think it's an interesting point, because it does highlight how important the communication and that sort of not only the safety net that we do have in reality, but people's perception and trust in that safety net really is. So partly people are being discharged quite quickly because there is a huge pressure on beds, and that is the reality. But partly people are the ethos of discharge to assess is that an assessment is much better done in somebody's normal residence. I can see that you're conscious of that, but it is very much the case that people it's a more accurate assessment of people's needs when it is, and it doesn't need to be in their home, it could be in a care home, but just in a more normalized setting than even a sort of hospital step down ward. So that is part of why the the assessment process happens in people's normal place of residence. And as Vicky says, I mean, I think it's learning in terms of the communication that people have with patients and about the reliability of that assessment and what it's there to do. And it sounds like that conversation didn't provide the sufficient level of reassurance that she needed. I mean, there are other things like a virtual ward type of system where somebody remains under the care of their consultant whilst they're in the community. So there are various different things that the hospital will be thinking about in terms of that bridge between hospital and home. But all of it doesn't mean anything unless the person really is aware and has that confidence. So we probably can't do much about it except to be aware of it. When Vicky and I which we do quite often, talk to the people who are managing particularly Cape Town ward, which is the ward that people move into at North Middlesex when they're ready to be discharged, and all of that kind of preparatory work and those preparatory conversations will often be happening.
So I'm just wondering, thank you, listening to the conversations around the table today, around discharge to assess, and there's two routes that seem to be quite clear. One is that you go through that reablement and then go back to your own home, and the other one is you're discharged from hospital to your own home, and then an assessment will take place, and whether that's around food, as Councillor Mason said, or whether that's again a bit more sort of in-depth OT. Is it a possibility that when people leave the hospital, they take away with them, as they take away their medication, they take away a card with them that says what those next steps are going to be? So if they're going into reablement ward, that's different. But if they're going home, who's going to be calling on them, when it's going to happen, and just so it gives that reassurance? Because I'm just wondering, I know full well myself, when I'm told something, especially if I'm in a hospital setting, it'll go in one ear, 3 minutes later, I remember 50%, in 10 minutes, I've remembered about 4% of what was actually told to me. So is it possible to have some sort of discharge card where you say, well, the OT is visiting you in 2 days' time, and if there's any extra support, this is the phone number, this is the discharge to assess team. If there's any urgency, please let us know. I mean, I'm just wondering if that's something that is already happening, Vicky. I know you've got your hand up straight away, so we're going to come straight back in on that. So over to you, Vicky.
Thank you, Chair. So when people are discharged, you see the list at the side, there is a conversation on which discharge route they're going to go through with that person on the ward before they leave. So there's 0 to 3. Somebody will come onto the ward. If it's a reablement bed, they'll have conversations. IDTs are the team that sat in the hospital. So that conversation happens. If they come home directly with reablement, with their medication, I would envisage, and I'm going to check after you've quite rightly pointed out what documentation is given to them, because I'm not absolutely sure, but if you will be kind enough to give me the grace for a couple of days, I'll go and find out what is handed to the patient. Or is it that they are met at home with the OT and the services, and they're assessed for what their level of need is at home? Would that be okay?
Yeah, thank you. That would be really helpful. And we're very close to time. So
What happened to me when I came out of Whittington Hospital last year?
Councillor Peacock's going to give you a very quick.
Very quick.
Yes.
They just gave me a breakdown of what the reason that I was in hospital, how long I was in there, and after discharge, and that's it. Just came in, gave me the piece of paper. Done.
Right. Okay. So you had a very different experience. So we're hopeful that your the records will show that there's a different way that is being captured. But yes, if you could come back to us, that would be great. And I think the other thing that maybe as a panel, I think we're picking up on Councillor Poku's question around sort of the funding. I hear what you're saying. I think, Rachel, it might have been you that said we're getting finances depending on numbers. But also within NCR, there is it's been recognised now that areas of deprivation should be getting, we should have that more weighted to greater amounts of funding. So I completely hear that your Beverly is sort of challenging this, I'm sure, in with the powers that be. But I think as a committee, I think we would probably just also maybe echo that and strengthen that from the scrutiny committee. I hope I'm right, colleagues, that's that we would be looking that, you know, areas of deprivation should, or the weighting of deprivation should also be taken, not just the numbers in the population, because as we know that different populations, depending on their access due to other things, they could be healthier because of that. So actually numbers isn't just hopefully the only indices which that's being determined. Any other recommendations, colleagues, on the Winter Resilience Fund? One last thing is around, I hear what you're saying about you're only getting that amount of money and then you're having to scramble to get things in place. Over the last, I know it's very difficult because of COVID, but pre-COVID, was there an amount that was similar? Were you getting a similar amount? Could you give start any form of putting things in place, or are you literally, do the amounts vary wildly year to year? And so just a quick question on that before we move on, Rachel.
So previously we were receiving an amount that was around £1 million for Haringey. It was slightly different because that was the amount that came in purely for health, really. It wasn't the same sort, it wasn't as targeted towards both the council side of discharges and health. And we used to get around that amount that we would use largely to boost capacity in step down beds, social worker numbers to support the assessment process. So there were some similarities, but this year I think because of the respiratory rate and the huge strain that the hospitals were under around their flow and the impact that was having on the ambulance waiting times, I think there was and because there was an integrated approach and the money went into both councils and to ICBs, there was slightly more funding available. But you know, the point is right, that every year we put on this additional capacity, and then come April, some of these things, there's a little bit of a kind of cliff edge that we try our very best to manage through. But it is difficult. It is difficult. So it is difficult for North Middlesex to go back to capacity. We're actually bridging that now through as far as we can to May. But some of the things that, like Vicky was talking about, some of the people who've got kind of more complex health needs, where we've been using this funding without prejudice, as in we don't ask questions about who funds, we make sure that the person has the nursing support they need. So that's quite a lot of the kind of job that for people like me and Vicky to do now, is to just work out how you kind of smooth that transition.
Right, thank you. It does sound, yeah, as you said, a bit of a cliff edge. If you're being discharged in April, you might get one service. If you're in June, you might get a different service because you had extra funding at the moment for the winter. But come May, then, you know, if people needed extra support, I'm just wondering where that funding is. And I'm hearing what you're saying about how that is smoothed and whether that can be over a period of time. So anything further on that would be really helpful for the next winter funding, because I'm sure we're going to be doing winter resilience next year because we do it every year. So I think that will be very helpful to have as part of the report. Anything else, colleagues, on the report next year? No? Okay. Well, thank you so much for coming along today. That's been really helpful to get that more in-depth understanding and scrutiny of what's been happening. And I know you've got a couple of things to take away, so I won't repeat them now, but thank you very much. And we'll move on to the next agenda item. Thank you, everyone. So we've got aids and adaptations, which is agenda item 8. It's the on page 27 in our agenda pack. And I've got Vicky, I think, I'm right this time in saying that you're going to be leading this one. Yes, Vicky.
So I'm going to open it up and I'm going to hand to Janet, and I'd like her to go through the slides. So thank you very much for inviting us back. Really appreciate it. We have been doing some significant work in this area. That we're on a journey. There is more work to do, and I'd just like to introduce Janet to the scrutiny panel. Janet is our interim head of service for supporting DFG's aids and adaptations. So when we met last time, I talked about that additional capacity. We were going to bring in expert capacity to take us on a journey. And this is Janet, who is an OT, and I'm going to hand over for her to introduce herself. Thank you.
Thank you, Vicky. Thank you, Chair. And good evening. It's really good to be here and to be able to report back as to where we are up to. I have been in post 6 weeks. So, and I am new to Haringey, so it has been quite a journey for me to get up to speed with the changes that have already been made and to bring about some additional change and to have the capacity to do some intensive work. So if you would like me to go through the slides, I can do that. So I think they start on your 27, don't they? So initially the concern from scrutiny was mainly related to the delays involved in quite a lengthy process, some issues around communication, and a little bit about, oh yes, please, that would be helpful. If you could put those up, that would be really helpful. Just seeing Dominic putting in the chat. Yes, then we're not talking to thin air. So yes, primarily the issues that residents, if you remember, attended and gave some really helpful feedback around communication in particular. So as a result of that, we've already made some changes. So that had happened before I arrived. So what I would like to do now is to look at what's changed in September and look at what the next steps are. So from, do you want to put the next slide up? Is that all right? I don't know if I've got power. So if we just look at page 28, is in your pack.
Next one.
Do you want it to move on? Yeah, I can't see the
Thank
page.
you. Fantastic, thanks. Yeah, so I am in post, so I've got a little bit more capacity to do that. So we have introduced standard letters. They were checked by homes. They were checked by how. Sorry, let me just find out. They were checked by Disability Action Haringey to look at the wording, did they make sense? And that's at each stage of the process. I think it was important to remember that when somebody comes to see you, don't take in all that information. So it's about putting that information in writing to people. That does include timescales, it does include contact information, and those have been in place for the last few months. From September, there was a number of people on that are in the system. Some were on the waiting list, some were in the system. Everybody had a personal phone call. So that took a little while to get through 800 people to check they still needed a service, to check that they understood where they were in the system and in the process, and to make personal contact, and to also apologise that the wait was quite lengthy. We have reduced the waiting times. We've got additional surveillance and additional assessment capacity. So I think that we've reduced it. So in August, we were reporting there was 812 people in the system. That has now come down to 448 because we've had the February statistics. So that 448 people, all of those people are either having work done, or they're allocated to a surveyor to process that work, or they've had that work completed. So that's not a waiting list. So there are, out of those people, there are 66 who've had the work done, but we're just catching up with the reviews. There are 125 people who have currently got works on site. So work is currently taking place. There's 184 where the surveyors are working to draw up those specifications, arrange for contractors or put out for tenders. And there are, as of tomorrow, there will be 73 that are allocated to an external surveying company. So the waiting list that we've got at the moment is for assessment, and we're hoping that in the next couple of weeks we will get that right down. So at the moment, I've not put that number in here. At the moment, there are 100 people voting for an assessment only, but we're hopeful that we'll get that right down in the next couple of weeks by doing some external contracting with a company. So that's the numbers. As well as the numbers, we're looking at what are people telling us, what are they telling us when they contact their members, what are they telling us in a complaint, and what's that telling us about culture that we need to change. So if I go on to the next slide, which is about what are we saying that people should expect from now on? Well, what we discovered is that people weren't always giving residents their contact details. They weren't always giving their phone numbers out. Residents aren't always clear which number they should be contacting. So all of those 800 people that were contacted were given a phone number. And now whenever we speak to people, we are making sure they know the phone number to phone, because we were getting feedback that people just didn't know where to phone. There are delays in the service. There are delays in getting things sorted because it is a complicated system. And I think in that, you might not hear from people in a couple of months and you just need to know where to phone. So we're also sending people a copy of the adaptation support plan, which at the 6 months ago, we were telling you about your support plan and giving you a copy if you asked for it. And I've now said to the team, you need to just say to people, I will be sending you your support plan. And if they don't want it, they can say, oh, no, don't do that. The person's support plan lists what their needs are. It lists any conversations that we've had with the person where we've not agreed with them or they've not agreed with us. And so it highlights what those areas are. And it also says what we're going to do and where we order equipment from, or if it's an adaptation and what that, a little bit about that process. So I think it's important that we are upping our game, as it were, in terms of giving people better written communication. The thing that I've started as of this week, slowly this week, probably more next week and the week after, is a system by which we proactively contact people, those 448 people that are in our system, that we proactively contact them around every 6 weeks. Just to say to you that while we do a bit of a check, where are they up to? Are we waiting for something back from the person? Or have they been allocated a surveyor? Does it look like things are progressing in an appropriate way? We get that information and then we phone the person, check how they're doing. Have they got any additional needs? Do they need further equipment? Or do we just need to be saying, we haven't actually got anything to tell you right now, but we haven't forgotten about you. And it's likely you'll hear from a surveyor within the next however many weeks that is. And also, and I've contacted a few people myself, actually. I contacted a lovely lady today who was really quite confused between the company and the surveyor and the OT. And it is a complicated setup where you've got different people contacting you. So I was able to say to her, okay, so this is the surveyor that works for us, and this is the company that's the contractor. So just trying to demystify that for people, because it can be confusing. And also we are committing to telling people what we're doing. So if we are putting something out for tender, that we don't need the person's consent to do that because they know we're going to do that, but we might have told them 3 months ago. So we need to start actually phoning them every time we do something in relation to their adaptations journey. So that's what we think people should expect, and the culture change that we are hoping to bring in. I think the other slides go through the actions from the last scrutiny. You can just, yes, it is. Excuse me a moment.
It's probably, I'm just wondering if, I think because we've all read them, is it all right if we just ask questions on these? Is that okay? Otherwise, you're going to be doing a lot of reading. because there's a lot on the slides. Is there anything you wanted else to tell us before we got to the slides? Because I think you've given us quite a bit of detail already. Is there anything else you wanted to bring to our attention? I know you've got next steps. Did you want to do that now, or did you want us to ask you questions first? What's your...
Do we do next steps? Let's have a look at the next steps, and then if we take questions, Chair. And the other thing is, what I've not put in the pack because I was a bit late getting it organised, is I've got a case illustration which I can share from my screen. So it's a child and just describing the adaptations that we organised for that child, which I think might be quite useful. I've got some good photographs as well, not of the child, but of the adaptations. So I think that might be useful if we could do that at the end. So the next steps, I think Vicky mentioned that we are on a culture. We're on a journey, but some of this is around culture change. So I think that the process is quite clear, but I think that process is important, but people are more important. And so what I want to do and what we want to do is work together to change that process into what does that mean for the person? What does it mean for the residents? So what does that, I know it's a bit of jargon, but customer journey, what does it look like for the person? And to draft that together with the staff, with the team themselves, and then to talk about that with some of the people that have actually had adaptations or in the process of having adaptations. So basically our service users. We're trying to get the waiting list down. So, but we're now moving to a stage where we need to bring the stuff out to do a series of workshops around culture, around the improving the customer journey, around making sure that asking ourselves, is this inefficient? Does the system not work here? What does it mean for that person that it takes 3 months for us to place the order? We batch orders together, so does that work? Is that more efficient? Is that a good process but bad for the person? And actually really challenging ourselves, and that does require a little bit of focused work to do that. So there's something about doing some workshops. I think we are doing I am personally doing some deep dive into complaints. We're trying to create a library of our learning so that we can say with greater understanding what that has meant to the person and what we need to change. So the idea of phoning people up every 6 weeks has come from the feedback that we've had from people. I think that's probably that on that slide. And on the next slide, I think we're talking about recruitment. We have 3 vacancies actually within the service: a team manager, occupational therapy and surveyor vacancies. It isn't easy to recruit occupational therapists. In fact, I don't think it's easy to recruit any staff at the moment. I think we're not alone in finding a workforce shortage. So we will be refreshing that, having another go at bringing in talent and trying to get people to come and work for us. We also need to say, okay, so we've got this amount of staff and this amount of demand, have we got enough? You know, is this around managing performance better, or actually do we just not have enough people on the ground to do the work? We are moving to a new system, a new client record system, and that will help us hopefully to track the timescales better. But also we need to align those timescales with government guidance. So the government guidance is we prioritise referrals that come in. At the moment, they don't. Apart from people who are very, very poorly and end of life, we don't have a really robust prioritisation method, and we need to have a better prioritisation method so that not everybody's going in the same pot all together, and we can use the government guidance to support us with that. When we've done that, we need to be a bit more transparent and have more information on the website for people. And I am in the process of looking at advocacy. We're not legally required to provide a formal advocate for people, but we have been asked for advocacy. So we are looking at commissioning that. but also looking at whether or not we can get advocacy from some of the user-led organisations as well. So that's the next steps. That's it. There's a little bit of caution around these timescales, if I'm absolutely honest, because this isn't an ideal world, how long something should take. And the persons I wanted to talk about, it actually took 12 months to get that work completed from beginning to end. Well, it took longer than that actually, but in the government guidance for a complex piece of adaptation, the expectation is from referral through to the person is really happy with their adaptation. They do allow 12 months. This is a complicated system. It's complicated to get any work done on any property if you're having a new kitchen or a bathroom, but if you're having both of those things and a lift and a ramp, it starts to stack up in terms of how long these things can take. And I think there's one slide.
I think that's probably it, Janet.
Yes. So the other slides, sorry.
No, if that's okay, because I think it gives us a chance to ask some questions and probably give you a chance to take a deep breath while we're going into the next bit, because I think that's quite a lot of information, I think, for us to sort of start with, and then we'll look at the individual specific requests from Scrutiny, if that's okay, as part of it. So just on that overview that we've just been given, I'm looking for questions from the panel or from anyone. I've got Councillor Bella, then Councillor Mason.
It's not actually a question, it's a comment.
Okay, a comment from Councillor Peacock, and then yes, so we'll start there. So Councillor Bella.
Thank you, Chair, and thank you for the presentation. I'm very new to this topic, so I realize my question might be very elementary. There's probably a very simple answer to it, and please excuse my ignorance on this topic. But going through your slides, the slides seem to presume that the resident is living in their own residence or they're living with family. But we do have private providers of adult social care in our borough. And I've come across private providers of adult social care in my work as a councillor who, for what seemed to me to be basic adaptations, like, for example, soundproofing, are going through the council's process to obtain those adaptations. And I understand they're also applying for public money to do this. And so I wanted to understand, in the case of a private provider who is applying for something relatively basic, should they be going through the council's process to obtain those adaptations? And should they be applying for public funds for those adaptations, given that I assume, but I could be wrong, that they are making a profit when they're providing their services? So is it appropriate that they're going through this channel, or for very basic adaptations, should this be part of the service they offer? Should they be offering these adaptations themselves? So I'm just trying to understand what the rationale is when there's a private provider involved.
Okay, thank you for that question.
And answer that. I'm not sure I'm clear what a private provider is. What you mean by private provider? Do you mean a contractor?
Someone who's a private company that's offering a residence to adults that need particular care. No.
Thank you. So the Disabled Facilities Grant legislation has a number of conditions, a number of areas where you can apply for grant funding, such as access to the property, making the property safe, access to bathing, upstairs facilities, bedroom, the garden, and so on. And so if any resident, whether they are a council tenant, a private tenant, they live in social housing, or they live in a caravan, any resident can apply for a disabled facilities grant. Soundproofing is an interesting one because we don't have many requests for soundproofing, but it could potentially be appropriate for somebody with autism who actually just can't manage that the sensory overload with noise. And so I've known of disabled facilities grant funding for people in that situation. Soundproofing, in terms of if it was an environmental issue, wouldn't be suitable wouldn't come under that legislation for funding. So this is for disabled or older people, and including children. Does that answer your question?
It does. That's really helpful. And again, if this was a very basic question, I apologize. Very new to this.
The basic question is there.
So I didn't know that, so I certainly didn't. That was really interesting. So I've got Councillor Mason and then Councillor Peacock, your comment.
Interesting. I think that was an interesting question because it's sparked something different from what I was going to ask, but so I will ask that if that's okay. So the question about autism and people who are living in very overcrowded circumstances. I have about 8 families in my area, and so I'm sure that's multiplied many-fold across Haringey, where children are living in a shared bedroom with 3-4 other children, and they have a care. Yes, so they're in a 2-bedroom flat. Parents in 1 bedroom, 3-4 more children. One of the children is autistic and is finding it really hard to live with anybody else, and I can't get them budged out. They can't get any more points, they can't get any more an increased band, but yet so there's nothing you could provide actually that would make life any easier for them, because they need a bigger flat to live in. And I don't suppose that you've got a few of those to dish out. So I just wanted to raise that it's not, that it's simply also that we need more flats, not just being able to deal, or more accommodation, not just deal with the people who need some adjustments. But the real question I wanted to ask you was about, I was really happy to see you talking about culture change, because that is so important and key to working with people in the community. One of the cases that I'm dealing with at the moment, which I have sent around the place, is somebody who was told that she'd be better off to make herself and her husband, who is bedbound, homeless, so that they actually own this property, and if she made, but she hasn't got any money, so it'd be better if she made herself homeless, so that they could go into some kind of supported accommodation. And she's been told that twice. And I was really shocked, because it must be a lot cheaper to keep her where she is. And she wants to stay where she is. So I guess there's people trying to get her in and out of the system. I don't think anybody was being horrible to her, but they're trying to maneuver the system so that she could, that her husband could have a reasonable place to be. But actually, the way of doing it would have been just to escalate her case. And she's been waiting for 5 months for an assessment, and her case should just be escalated. So it shouldn't really have to come to me. This also went to Catherine West, and it's flown around the place more than once. And there must be a way in which cases that are urgent can be escalated, rather than having to just sit at the bottom of a waiting list and chug through. I was quite surprised how small the waiting list was, that she hadn't managed to get up higher on it, given that this guy's in a bedroom and can't get out. So, but real question is escalation of cases, and is there a way in which we can do that?
Yes, and when I talked about prioritisation, I guess that's what I mean. So at the moment, I'm not seeing a lot of prioritisation. So people go on their waiting list of date order. And that's not to say everybody's important, but actually some people have got higher risks than others. And if we feel the risks are so high that the best advice that somebody's given is the advice that you've described, clearly that's a higher level of risk, isn't it? So I think that you would hope, wouldn't you, that the escalation is the members inquiries, but also talking to a colleague today, we also know that it's not easy to get hold of the first response team, but there have been an additional 4 customer care officers who are now in post, and we're now able to track the phone line better. So we're able to track the times when people are not being able to get through. and also be able to track how many calls individuals are taking, which sometimes drives up performance. So I think that will help. And just going back to what you said about overcrowding, and it is a real issue, isn't it? The legislation is very, very clear that we can't agree to a grant for overcrowding reasons alone. However, if under normal circumstances, two siblings would be expected to share, so they're two of the same gender and over a certain age, and they would have normally been expected to share, and that's not possible because of a disability, we can apply for a grant and we can carry out an assessment and look at additional bedroom facilities. If it's possible, it's not always technically feasible, but if it is actually possible. So that's just something that's worth bearing in mind, I think.
Okay, thank you.
Okay, thank you. I've got Councillor Peacock for your comments.
Yeah. Janet, I shall be emailing you tomorrow. And I hope that if you're not the right person, I'm sure you'll point me into the right direction. I had to visit a lady today on the 3rd floor in a block of flats, and they very kindly put handrails up to the 2nd floor. So it didn't go up to her floor. So I'll be writing to you about that to see if we can get the handrails to continue up to her flat.
Okay, well, thank you. There we are. That was, you're forewarned. So I've got a couple of questions from the scrutiny report that you provided to us. I think for me, I have to say, the time frame, the government guidelines of 12 months for a major adaptation, I find just absolutely incredible, because I noticed the Haringey one was, I mean, I was trying to read it. I think I approximated it at 6 months-ish, if there was a fair wind and nothing went wrong. But even so, I'm just thinking, so say somebody had a stroke, was in hospital, needed major adaptations to go home. You know, I know we wouldn't be putting in this sort of work until they were much better in hospital, otherwise through the reablement process. But then that does sort of really give that concern that somebody is going to be out of their own home for potentially another 6 months because it takes that long for this to be done. Janet, I did note you said something about the number of people that would be required, you know, the workforce needed and the difficulties in actually getting that workforce into Haringey and probably all around the country. Actually, I don't think this is just Haringey. But is there something, have we got that capacity? So if there was 12 OTs out there, I know there isn't, but, you know, I'm just being, or surveyors or other people within this contract system, is there a possibility that we could increase the speed of this process? Or are you saying that actually that 6 months-ish is about the right amount of time? Because we've just been talking about winter resilience and getting people back into their own homes and how important that is. We're getting that on one hand, but on the other hand, we're getting this system whereby it seems to take a large amount of time. So I'll start with that question, because that's quite a tricky one, I think.
Yes, so the guidance from the government categorises adaptations into urgent and simple, non-urgent and simple, urgent and complex, and non-urgent and complex. And so the longest time is the non-urgent and complex. So that's the 12 months. So urgent and simple gives a total guidance time of 55 working days, which is a couple of months, isn't it? So for me, a non-urgent and simple would be a stair lift or a level access shower, or a stair lift and a level access shower. Those are the straightforward, or should be straightforward, adaptations. When you start trying to organise a third floor lift that has a lead time of 3 months from order, you start getting into longer timescales. And so I think it's about being clearer about how many of each adaptation we're putting through, what is a complex adaptation, because it's not just the adaptation, it's the complex, it's the people we're working with. Some people with chaotic lives, some people who are looking after residents who have really high level complex needs. And so negotiating, and these are people's homes, so there's some negotiation that takes place about which room will we put the food monitor in, how will we organise with after, because it's their home, so people have a view and they should have a view, but sometimes people's views and professional opinion, we don't always agree, and so that takes a little while. It's delicate and we have to negotiate, and that's why we employ professional therapists and social workers to help with that negotiation. And so I think your question was challenging the timescales, which that is the longest timescale for a very complex piece of work, possibly an extension. So you wouldn't expect to be building an extension in 2 months, but equally you wouldn't expect a level access shower to take a year. And at the moment, they're all bunched in together and we just can't quite work out what's what. And we need to be clear about what's what, so we can report back to Scrutiny to say, yes, our showers are taking this long, because they're not as complex and they're not as urgent as somebody that can't get upstairs to the toilet. So we're clearer on need.
Thank you, Janet.
You asked a question about workforce as well. Could we increase our workforce? Honestly, I don't know at this moment in time. I see there's a lot of private practice that's sprung up, because most local authorities have long waiting lists, and we want to allocate 100 cases at once. And the easiest way of doing that is to contract out. And so a lot of people, and they're doing a really good job actually, they're good, and they're not getting a worse service. So there's always been a shortage of occupational therapists. There's even more shortage now because we are contracting out. But I think Haringey has a lot to offer, because it is an OT-led service, it is centralised, we're reducing the waiting list, there's some energy behind what we're doing. So all I have is optimism about whether or not we will manage to recruit, because we've got to, we can no longer put an advert out anymore that says we have an exciting opportunity for an occupational therapist. We have to sell ourselves. And for that, we have to get people that are really good at writing adverts and really good at selling themselves. And we say to people, come and meet us. Don't apply, just come and meet us first. So I've got people in working where I worked before. I've managed to get people working for us by saying to them, don't apply, come and meet me and have a cup of coffee with me. And then let's have a chat, because you're just trying to kind of coax people in. We're selling here, aren't we? We're having to sell ourselves.
Thanks, Janet. Okay, so that's really interesting actually about the workforce and where we're at, and that sort of length of time. There's a couple of other things that you mentioned around the website, improving information on the website, around getting advocacy up and running, and particularly around the co-design, which I know we're very keen in this council to promote the service. So co-designing the service with people that are have used this service or in the process of, I'm not sure what you're looking to do. So really on those 3 areas, and you mentioned those, whereabouts are you in those sort of timescales in relation to be able to getting something a little bit more concrete to Scrutiny and say, right, well, the website we're looking to do by end of September, or whatever it is. It just really gives us a sort of clearer idea of your time.
Yeah, so I'd like to start the workshops in April. So I want to take the staff out for mornings in April, May and June. So really it's going to be the end of May before we've got something that we've produced to be able to show people. But I also think that some of the listening to people is already happening. We're just not doing it on a big scale, because we are phoning people up now when they are contacting us or making a complaint or contacting themselves, because I just want to understand people's experience. So we're beginning to get, well, when I say we're beginning to get a group of people at the moment, I've got 2. So we have 2 people at the moment that we've highlighted that would be really helpful to work with us. And people, when they work with us, as you know, they need to tell their story first, and then we can usually work together to get some feedback on things. So I'm only in post for 6 months, so I have to do that by 6 months, don't I? So yeah, I did think about that, because I think, like I said, I've been in post 6 weeks. Some of this work had been done before, so there's a lot of groundwork that has been done. The numbers have been falling, and so really team members should have a little bit more headspace now to start thinking about, okay, I don't feel like I'm fighting fires quite so badly. Let's think about actually being a little bit more strategic. So we need to start this in April. And so I was thinking about the consultation by the end of April, May. So recruitment April, review June. I want to get timescales up and running in April. Yeah, I think it's, sorry, I am blurbing a little bit now, but I think it's a little bit about how much we can work with staff, because every time we pull staff out, we pull them away from the day job. So that's what I'm mindful of as well.
Okay, thank you, Jen. And the improving the website around people being able to easily click on a link. When's that? What's your thoughts on that?
I'm going to say let's do that in May, because I or even June, because I need to put something there that's different as well.
Yeah. Okay, because I have to say the actions requested by Scrutiny and the information you put underneath does feel very different from where we were previously. I know we haven't gone through all the slides, but especially around the offer of an advocate and the way the communication is with the residents in future and the explanations. So it's really helpful to see that on the slides. It's really useful to us to get that understanding. And that final bit on advocacy, is that something that you're in discussion with different groups to look at providing advocates for that?
Yes, I'm in discussion with Power.
Okay.
Who have provided a cost. So they are the people that I am due to meet with. And I guess I think what I would say about the timescales as well is we have appointed a project manager, and I'm really hoping that we will work together and we'll put everything that we need to do, and we'll put some actual target dates in. So that we can
Right, thank you. I'm just going to look around my colleagues if there's anything they want to ask, maybe on the updates on the slides. No, I'm seeing no. Okay, so thank you very much, Janet. I know Vicky and as I say behind the scenes, but I'm sure you've been there alongside with Janet getting this information to us to Scrutiny, and it is really helpful to have this in a very clear format of just being able to tell us where exactly you're at with this. I think for us, it would be really useful to get an update once you've gone through this process and really understanding so about the website, the advocacy, the co-design, the timescales, and about that workforce, and whether, and you're looking at about contracts, or whether we sort of try to build our in-house team and how that's going. So I'm sort of looking at sort of beginning of next year, sort of September, November time. I'm going to look to Vicky or Janet, if that's something, we'd have something to come back to us, Vicky.
Yeah, I'm absolutely more than happy to bring something back at that point. And if we manage to get something more concrete before then, more than happy to just send something round, just to note really. And if I just may come in and say thank you, Scrutiny, that it was my first scrutiny coming into the DFG, and you challenged us quite correctly, and we are on a journey, but I am hopeful that collectively we're going in the right direction. So that feedback we're getting from members, the feedback from service users and internal staff is really supporting us to reach better outcomes for our residents. Thank you.
Thank you. And I think for us, particularly from the Scrutiny Committee, the bit that we're going to be really interested in, and this won't surprise you, is feedback from the residents on this new set of, because as you said, this is in transition, it's already happening, but actually it's really how that works alongside residents and whether they see this as an improvement. So the proof is in the pudding, and I'm going to ask you how you're going to be able to get that feedback. Are you going to look at complaints, or are you going to look at a different way of just trying to get some information from the people that are going through this service? I know it's very difficult to ask people who are in the process of having their things done, in case they think if they give you a negative rating, then they'll be pushed to the back of the, you know. So I'm sure you'll find a way of doing that that maybe is an easier way for them to make honest their views known without it sort of them feeling that they're sort of impacted at all. Vicky, did you want to come in last? Your hands,
please. Final comment. Yes, thank you, Chair. So we're going to use a multitude, and that user experience and lived experience. I know Janet has met with individuals that previously highlighted some issues that they'd experienced, and she's met with them. We are continuing to meet with them, and we will use multiple different ways of getting that feedback. And one of them is complaints, one of them is that co-production around the pathways, the other one is user feedback, experience, and we'll bring something back at a later stage just to evidence the multiple pathways that we've used for that feedback. Thank you.
Right, okay. So thank you very much, and thank you, Janet, for attending your first Scrutiny committee. You're more than welcome, and thank you so much for going through those slides and answering the questions that we had for you tonight. So thank you both. That's going to finish this part of the agenda item. So thank you. And we're going to do the Q&A session with our cabinet member. So agenda item number 9, Q&A session with Councillor Snevs. Very funny being so close. It feels like a cup of tea should be there and a biscuit. Yes, tea and biscuits, that would be nice. Okay, so we have got the final item. So question and answer session. Over to you, Councillor Snevs, if you want to give us a little brief update on what's been going on, so you can set the scene, and then open to the floor for questions from the committee. Thank you.
Yeah, I thought I'd share, probably not everything, but just share a few highlights of some of the priorities before, and sometimes I've talked at length the whole service and as we see it. So I thought I'd just share some of the things that I've been involved with recently that relate to some of the bigger priorities that we've highlighted. The first thing is we recently held mental health is a key area for us. It's been an articulated priority. And one of the things we've recently done is Will and the team held a workshop with all the providers of mental health across the borough to talk about what's already there, but also what the gaps are, etc. It's a really useful event. We had a range of the providers, obviously BEH, Mind and Haringey, but also some of the smaller organisations, some of our voluntary sector and more community-led organisations there. And I think it's a part of a journey, which is looking at, councils have been really concerned about some of the casework they're seeing in their inbox around mental health. So we talked about those very things, those things where we're seeing people move up and down in their acuity, in their need for a service. How do we support them when that's happening, but also how do we have more preventative action, and how do we make sure we've got the right services in those bits, maybe in between, in those gaps. So that's just a first step, but really important part of our focus. Gambling harm is a really important piece of work that we're doing in the borough. You all know that we are limited in how we can prevent these establishments opening in the borough and being on our high streets, and we're challenged by that. However, we have made some real efforts to make sure we have the right services in place, and we quite recently, because it's January by now, but it feels still recent, held a summit around gambling harm. Really successful event. We had some quite important figures in the, I suppose you'd call it, gambling harm sphere, including someone called Henrietta Bowman Jones, who's spoken, she's a doctor by practice and spoke very eloquently at the event around some of the challenges around gambling harms. And of course, while we're waiting for a government white paper, what we've been doing, we've been successful in having a greater amount of support for people within the borough, working with the organisation GamCare, who have provided some workers and are actually working with people already in the borough. So really important, but part of that journey is also about on behalf of local authorities and making a case for us wanting both making the case for needing greater support and funding for that support, but also the case for us, the ability for us to have and be empowered by legislation. And we hope that the white paper will bring that forward. And part of the purpose of that summit was to focus in, we had a whole mix of professionals in the room, and to focus the mind on the issue and how it's affecting our residents, but also to help us on that journey of influencing government and what they want to do. So really important part of our work. And then violence against women and girls, just picking up on last week, International Women's Day, and I visited one of the secondary schools in our borough, and we had a worker from Solace who worked with us on a project in schools, and really good conversation with young women, really clear what young women are experiencing in schools, and it raised for me some questions about how we make sure that that all girls in all schools, but particularly in our secondaries, but also looking at younger too, primary, have access to those conversations, but also boys too, and really good conversation with those young women around what they thought was good about having a women's or girls group, but also what a boys group might do, what a mixed group. So we obviously have Solace working with us on that project, but for me, it's a question of how we make sure that all schools are getting what they should be, and that those conversations are happening also more broadly with families too. So families, parents, carers can support, etc. And we're also in the process of commissioning our services around violence against women and girls in the borough. So we're about to start that process. So there'll be something for, I think, Scrutiny to look out for, is that there'll be a process which will involve counsellors, but also will involve those with lived experience, etc., looking at our services. You'll be aware, I think I might have done this in a previous update, that we had some funds and we've extended our services and increased our reach. So we have services for older women, which was a gap, and also for LGBTQ plus women too, so that we're making sure we've got those specialist services for interventions with women. So that's a flavour of some of those, some of the priority areas that I think I've highlighted before. But over to you for questions about anything really.
Right. Well, I'm going to kick off because you've mentioned two things I'm really, well, three things. The three things actually I'm really interested in. So the Gambling Harm Summit, that sounded like an excellent event. I just wanted to ask, because as Ovian Scrutiny, we took evidence and from residents, and we made recommendations around having a piece of research to be done. And we were told in, and I'm going back now quite some time, so forgive me if I don't get this quite right, but from my understanding, we had to, if you had a piece of research that evidenced the harm, it gave greater weight. Otherwise, within planning, you know better than I that you can't prevent gambling establishments from opening up. So we were told that the research was a way that another council in London had used to give weight to their planning committees in order to refuse some. So I'm just wondering, so my first question is, are we still looking, because we were going to be commissioning, but this is now going back probably a couple of years now because of COVID. So is that still something that we're going to be still looking at? And my second question is on violence against women and girls. OSC is currently doing their main project piece on violence against women and girls in schools, and we're looking at secondary schools. And I know that a couple of members on this committee are actually have joined the OSC to sort of look at that as well, because they have particular interest in this area. And we were particularly interested in just what you've been saying about extending that offer to all within the secondary schools around those conversations with young men as well as women around that challenge and around the new influences they're constantly being bombarded with and how we can best support them to those choices. So my question is, are you saying about new commissioning of services? Is that something that's going to be happening quite soon, or is that something just because of actually from what we're putting into our scrutiny, what we're scrutinising in the within secondary school setting? Is that something that is coming down the line, but a bit later on? I'm just trying to work out where OSC, is best placed really around that sort of commissioning process. And I'll stop there with my two questions and let my other colleagues come in on others. But yes, those are my first two.
So answer those first, yeah. Okay, gambling harm. Yeah, interesting one. So you might be aware we're waiting to hear on some funding. We've been waiting a long time. It feels like maybe we're waiting because I started thinking we're waiting because the government are thinking about their white paper and bringing it out. I don't know if that's a factor in it or not. A few weeks back, it looks like the white paper was going to appear and then it didn't. So every so often that seems to happen. I feel slightly cynical about it because I think a few weeks ago it happened and it seemed to be being discussed at a group which was a gambling industry lobbying group. I was a little bit concerned about what that might mean and indicate about the white paper. But so what's really good is that's one of the reasons for doing the summit is about having that conversation and interest. We had there's some quite good conversations post that summit with some of the individuals who would naturally have access to both data, but also really interested in doing that deep work. So I don't know the full answer, and will we get a research project imminently? I don't know. Some of that's about funding and also about what opportunities and expertise we can attract. But we are uniquely placed, and we're in order to do that because we've lined up our ducks. And we were hoping to do a piece of work that would also involve another London borough. And that would be about, although it's about Haringey and that other London borough, it's also about London-wide some learning. So that's what we're waiting for really on funding, but also those relationships. And we had some really significant people at that event, including from the Gambling Commission. So that means that we're hopefully being taken really seriously in what we're trying to achieve.
Yeah.
On VOG in secondary schools, I might bring Will on some of the detail about the commissioning and that length of process. But I think that anything that OSC shares with us is I think it's the right time. I think it's always the right time. It also focuses the mind. So I think it's definitely an issue, and I think it would be really good if we're addressed that I think it's great that we're addressing it at OSC because I think it's something that not everyone's aware, and families and parents are not aware. We're not acknowledging, and we're still, even though we're talking a lot about VOG, I think we're not acknowledging some of those issues at school. You'll remember that the year before last, we did a series of 3 films with young people with Solace, and there was one which was, I guess, a girl's perspective, a boy's perspective, and then a kind of mixed group. And we presented those at Haringey Sixth Form, and really was really clear feedback from them. We presented it to young women, and the feedback was really clear around, actually really broadly, they said, we feel really sexualized by society and objectified. And it always really challenging to hear that from our young people. They're telling us that as adults, that's what they're saying. So really important for us to listen to those messages and to really think, well, what is the coverage that we've got in all our schools? And really useful conversations the other day with Solace about, even at primary, what conversations can we have in year 4, in year 5, in year 6, and in that transition that came up the other day, really that transition between secondary and primary and what that means for boys and girls and some of the things that they might be experiencing or they might be doing or participating in, to be blunt. So I don't know, Will, if you've got any comment on the timings that Councillor Connors asked about.
Sure. Hi, hi there. I'm Wilmer Maris, Director of Public Health. So I think the first thing to say about the Protect Our Women programme, it's a really innovative programme. We had a London-wide meeting recently on VORG, and it was kind of acknowledged that other boroughs aren't haven't got it in place, and it's kind of recognised as good practice. But it is a small project, as we're finding out in Scrutiny. So any recommendations from Scrutiny would be really welcome, because we're extending that programme as is for at least another year. So we've got a bit of lead-in time for any review of that service. So yeah, it's as it stands at least until April 24, and with plenty of time for planning any changes.
Thank you, Will. Okay, well, thank you so much for that. That was really helpful. I notice I've got Councillor Mason and Helena who've also got questions. I'm just going to look down the lines. Anyone? Yeah, no. Okay, well, you all know your orders now, so I'll go straight over to Councillor Mason. If you just ask your questions, then that would be great. So if we take Councillor Mason and Helena first, and then Councillor Bennett and Councillor Bennett next. Thank you.
Great, thanks a lot, and thank you, Lucia, for your reports. Really interesting. There's just a couple of brief things about children in schools and the change in legislation with the Domestic Abuse Act and children as victims. And so I'd be interested to know how we're particularly looking at that area, what support is being given to children who have been victims of DA. And the other part of that is, thank you, Will, for the work that you're doing and kind of trying to extend how we encourage boys to be advocates and girls to be advocates. So the whole object of the programme that was running in Haringey, or is running, is to make sure that children themselves are leaders. We're changing the culture rather than just changing rather than doing individual work and it being top down from teachers to children, but that children are involved themselves in challenging each other around areas of violence against women and girls. So I just wanted to know whether explicitly around that there is more work being done and how that can be rolled out. And then finally, the final question I've got is that one of the huge barriers in working around domestic abuse is multi-agency working and also multi-department working. So one department working almost opposite to what the other department is doing. And I just wanted to know whether you've got any work going on that or any ideas on how to improve that. Thank you.
Okay, and Helena, do you want to ask your questions?
Yes, I'm sorry, I'm going to stay off video. I've got very little
That's okay.
power. Back to my big thing about prevention, and I wanted to ask about annual health checks, which are supposed to happen. I wanted to know whether we've got figures for how many should happen and how many do actually happen, because my feeling going around the health service is that there are a lot of people that just do not get an annual health check. And this would be really helpful in stopping people getting iller, etc., etc. You know the reasons, Will knows the reasons. I just want to know what is happening about making sure that these are happening. Thank you.
Okay, so Councillor Sneves and then officers to come in as.
Okay, I'll go through. So thanks, Mary, for your points. I think you're quite, your points Mel made around children themselves leading. So you'll be really pleased to hear on last week when I was at the session, the outcome really was about those young women saying, okay, we'd like a group. This is how we'd like to do it within the school. And of course, now that I'm hoping we'll be able to support them in navigating that and them leading it. And their voices were so clear and strong. So I think that's absolutely, that programme is still very much focused on that way and on those young women, although admittedly I wasn't in that group with boys, and some of the conversation was challenging around some of that work, but absolutely. I think we do have multi-agency working. I don't doubt that we can always do better, and I note you say multi-department, and I can sort of imagine what you're thinking about there within the council as well. So I think that's a good challenge. and Will might want to come in, but we might also want to take that away and have write a better response back to you as a written response. The Children's Schools Domestic Abuse Act, I think we should do a written response to you if that's okay on that one. And annual health checks, it's a good question, and I must admit, I don't know the answer, Elena, and Will might not off the top of his head either, but he might have some stats, but we could come back and, well, I can see Vicky's putting her hand up, so Vicky might have an answer, but I also think we might want to do a written one on a bit more of the detail and the figures on that. So
that would be really welcome. That would be welcome. Thank you.
Okay, so can I bring in Will first, just because he keeps being mentioned, and then Vicky, I know your enthusiasm, but we'll bring you in second. Thank you.
Yeah, just wanted to, there's two things. So the support specifically for children in schools. So we've recently commissioned domestic violence advocates specifically for children, known as IDVAs, and that's new, and we're just going to loop them into our pathways and work with, of course, with children's social care on that. So I hope that answers that question. On the health checks, Helen, it'd be useful to have a bit of clarity around that question, because there's a number of different checks. So we commission in public health the NHS health checks, which are age 40 to 74, and they're every 5 years. But then there's other checks for people with existing long-term conditions, which will be done by the sort of annual reviews by the NHS, and then checks for people with mental illness. But I'm assuming it's the NHS health checks, and we can provide some data on that. On the NHS health checks, our budgets were under significant pressure a number of years ago, and we made a decision to prioritise the east of the borough due to the higher rates of cardiovascular disease prevalence there. It has been challenging getting GPs to pick up those checks, particularly during COVID and the aftermath with primary care being stretched. So we've recently commissioned the GP Federation to sort of pick up some of those checks. But in terms of the numbers, we do need to get back to you with the sort of latest figures.
Thank you.
Vicky, would you like to come in?
I do want to come in, thank you very much, and it's our time to shine. So I would just want to share with you really, really good news. Annual health checks for LD, children and adults over 14 years of age. The January data showed that Haringey is the highest performer in NCL at 72.5, and the national target is 75% in year, and in January at 72.5. And for 22-23, this is the first year that Haringey is not the lowest performer in NCL, and that's from our learning disabilities partnership team that Andrea Kelly is the head of. So fantastic news for Haringey across NCL. Thank you.
Asking why stop to 74.
Yeah, sorry. Thank you, Vicky. That was really good to hear. There's a very quick follow-up question, Will, on age around health checks. Thanks, Peacock.
Why stop at 74? Lots of my pensioners are in their 80s and 90s.
So I guess that after age 74, people will be having more regular reviews with their GPs in any case. So the focus is on prevention before you get to that age. So the people older than that should be seeing their GP more regularly under sort of different schemes. So yeah, you wouldn't stop. You would want to be getting checked regularly, but it's a different scheme, I guess. It's not the Public Health Commission scheme.
But I'm in my 92nd year, and I haven't seen a doctor for a long time. They don't check on me at all.
Well, maybe that's because you're so fit and healthy that you're yeah. But yeah, you would have thought that they'd be doing things like cholesterol checks every so often.
You never wanted.
Too fit. How old do you say, Councillor Peacock?
She'll be 92 in September.
Oh wow. Okay. You don't look it.
That was a good reaction. So I'm not sure quite what else he could have said actually on that one.
What Sheila needs to do is send around all what she's taking. It's really working very well.
Indeed. So just to bring us back to the last part, are there any other questions?
Got a long one, I think.
Oh.
I did have a question about Solace workshops going into schools, actually reaching into the schools, and doing work about VOLC, because I understood when we had our meeting about it previously, we were saying that we'd only gone into some secondary schools, we've only just started going in. So I just wanted to know something about, have we got a target when we will, or do we intend to go into all the secondaries? Have we got a target date when we're going to reach all the secondaries, sort of done work in all of them?
No, I don't think we have got a target. I think the point is, I think it's a good question. I think the point is about resourcing it, but also prioritising where we might want to be in quick sooner rather than later. But that's to be confirmed. At the moment, I think what Will was saying is we're at a situation where we're going to extend the project for another year. But hopefully, once the scrutiny review has said we should be doing this for much longer, we might well find that we can resource it for a longer term and have, because I suppose there's something about going in, but I guess the other thing I'd add is how we then support that going forward and make sure they manage and maintain, and the young people have adequate support. And what I was struck by last week was just how well the young people responded to the Solace worker, how it was really clear that she was enabling those young women rather than it being too done to. But that in itself is a skill, and it's probably certainly I think it's best placed with organisations and people that way rather than school or the capital. So yeah, I guess I'm fudging it. I'm saying that we ideally like to go into every school as soon as possible. It's going to take time, I think.
I'm more concerned that we do go into every school. You know, I mean, you can't go into them all tomorrow, but I do think it's quite important that we do cover everywhere. You know, you can't have a bit of the borough just totally.
So I think Clippers can write that down as a recommendation from cabinet members' questions. The strong opinion was that we should go into all secondary schools, and I think the main review, I guess, will advise us on that, and that will help and support what we probably all want. So heard and understood.
Okay, well, there you are. Your recommendation, Councillor Brennan, has been duly noted, and I think probably agreed by everyone on the committee. So, oh, sorry, Helena, is your hand still a legacy hand? Because you asked your questions. I'm just checking if that's a legacy hand.
Yes, sorry, it is a legacy hand.
Okay,
thanks.
Thank you for the presentation, Lucia. You mentioned that GAM Care are offering support services to residents that are dealing with gambling addiction. Could you explain to us what kind of support is available, how many approximately people are receiving that support, and if more funding were to be made available, how would you want to scale up the programs?
So I mean, there's a good question. So at the moment, people can access a helpline, and one of the things that's really important, and why the mention of research is really important, because the data is quite scant, and GamCare themselves will say that, and actually the data is also really important but how we might measure data and how the Gambling Commission does is different too. So getting good information and just recording how many people are using. So there's a helpline, but what we've got that's different is we have 2 workers who are going to come in, and I think my understanding of that work is that it's very much quite coaching and kind of psychosocial support. When you think that a lot of boroughs won't have any of that, we are ahead of the game. I think I'd want to do a written response on a bit more of the detail about what we'd like if we had infinite money. But I think part of it at the moment might not just be about money, might be about us just learning how we do this and how it works. It's developing in a really nice partnership way. So our workers are going to be in the high street. I think one of the high street banks, we still have some left, are providing space, because it's really good for it to be quite a neutral and different kind of space, and out on a high street where people can kind of just come in, as you can imagine, and access that support, having pre-arranged it. So that's emerging, and how we do it and that learning is part of the project. So I don't know that we can quite answer yet. If we had more money, how would it look? I suspect it would be more people doing that one-to-one support for people, probably. But I could do you a bit of a written response, just a bit more about how it's working.
Okay, so before we go on to further questions, I think I think the committee would strongly support that. Piece of work on the research is done. I know you're waiting and you're making sure you've got all your ducks in a row, sort of thing, and you've had the Gambling Harm Summit. But I think really to get that strength, I think that what we had at OSC, that seemed to be like a vital part of that puzzle, alongside everything else that's being done. Just to give us that sort of slightly more strength in pushing back. Now, how that white paper fits in with that.
Yeah, I mean, I think it's and I reread over actually your report, because my perception, and I'm not pretending to be, licensing's not my area, but Kat's Carlin here, she might say better than me. I'm not that persuaded. I'm not that persuaded that that evidence will enable us to prevent. I know we did a lot of work. And even when we've been able to provide some police evidence, which I know is pretty much the strongest evidence, we haven't been successful in stopping. But I don't want to say that no London Borough has achieved. And actually, the research is necessary anyway, because we need to be able to talk competently and confidently about what the issues are. So yes, absolutely. And I'll relook at your report and remind myself around that bit of, can it help us? Because there's a lot of lack of confidence out there around actually the ability to prevent, and also the different kinds of services that are now emerging. So of course we have betting shops, now we have adult gaming centres, and what we're seeing with those is that some of those very prevalent and obvious harms that we've seen on our high streets around ASB are less being seen less prevalently with some of those centres. So therefore, in a way, the hidden harm is greater, the gambling harm, but whether or not we'll actually see in that uptick in some of those police figures and some of that which seems to have most influence on us. But I'm straying into something it's far from my area of expertise.
No, it's good to hear, because we were just it was very useful having licensing at the OSC, because they rightly said, as you said, they don't know if it could, but it's the only thing that seems to be accounted for when challenging having gambling places opening up. So you're right, there wasn't evidence to say, yes, this will work, but that was the only thing that they could think that would actually have any impact.
From our point of view, then, any piece of research we do, we also need to work with the right people,
yes,
have that right credibility, and will give us that kind of influence we might have. And the challenge we have at the moment is that a lot of people are waiting for this white paper, expecting it to then prompt them to think about how they might respond to what the government's proposing or not, as the case may be. But yeah, but I'll relook at that. And we're absolutely I'm also raising something else you've got, which is to have a gambling harm champion. I know that's all on the agenda.
Excellent. Now I've got Councillor Poku, and then I think Councillor Peacock wants to do a follow-up question.
Thank you. I was just picking up on this gambling. I know it's very difficult license. It's very frustrating when you actually know that we don't need more betting shops on the high street, and you put an application to reject their proposal, but yet because you're quite restricted, it gets approved. So my one is, there's the white paper that we're waiting for. I don't know what's going to happen on it. But I'm sure there are other councils nationally that are affected by that. Is there anything that councils can do together just to lobby the government?
Yeah.
So that at least, you can prevent those kind of things happening, because it affects the nation.
Yeah, absolutely agree. The real problem is the legislation is aimed to permit, so therefore you're already kind of on the back foot before you've even taken a breath. Yes, and I think, and it somewhat predates me as a cabinet member as well, because there has been an all-parliamentary group on gambling harm. There was a consultation which lots of local authorities submitted to. You'll know that I wrote an article not that long ago, all with that same aim, and I've been in conversation with some of my NCL equivalents around this issue. We all feel the same. I think the next step will be, when the white paper comes, is us then writing a response to it, which undoubtedly we'll do. and it might be good to see a London kind of response. But we're waiting.
All get together because if we're all you're not going to listen to
Yeah.
stuff.
So I think a lot of the things that we would like to see have been fed back, and then it will be, you know how legislation works, it will come out, they will have put on the table what they've put on the table, and then we'll come together, I think, absolutely, and feedback our views, write some letters to the minister. I know Catherine West said she was going to write to the minister as well about some of the challenges that we've raised more recently and our frustration. It's that kind of drip. We'll see.
Okay, well, thank you very much. Councillor Peacock.
Well, I could talk endlessly about gambling. I could. When I was chair of licensing, we turned down an establishment, and they took us to court and they won, and it cost us an awful lot of money. And I remember when the legislation first came in, it was to stop all the people on the street corners taking bets. A lot of the people that use the gambling places are in there to keep warm, because they're generally men living on their own and it's cold, and so they're in there to keep warm. Unfortunately, my partner spends most of his time there as well. But that's not because it's cold at home. But the things I can ask you is about dementia, because you spoke quite eloquently to me about dementia before, and you said you're bringing somebody new in, or looking at it in a different way, or doing something. Because as you know, I take lots of, not that I've got dementia, you understand, but I look after somebody who has got dementia, and I take them to various places. And you said something really interesting about it when I spoke.
Yeah. You've reminded me. I went on dementia, virtual reality dementia training. It was an extraordinary experience. So it was in Wood Green, in a van. It was one of the most extraordinary experiences I've ever had. I can honestly say that. Obviously aimed at simulating dementia, and some people who are working with people in dementia in the borough were going on that training. So yes, it's quite revelatory. You'll know that we have some really good services in the borough, and we've recently, I think they're starting this month, Beverly, is that right? A new dementia coordinator that's going to, I think, supercharge some of our outreach work. Is that what it was? Yeah, I could have done a little bit of my spiel, right? Yeah. I'll consult you next time before I talk to you. Thanks. So I think that's really exciting, because I think we've got, I can't remember, what is the alliance called? Dementia Friendly Alliance, Dementia Action Alliance. So the coordinator will, I think, reinvigorate that and help us get out in the borough more. Obviously, we have the Haynes and we have some existing outreach. We have things called Tom's Clubs already, but it's about boosting it. And it is on my mind, especially after, I mean, you know, I've got I have personal experience in my family with dementia, but also doing that training was quite revelatory. So yes, more to follow. I think we could bring some of that back, actually, once that person's a bit more in post and settled in, we could come back with dementia.
Thanks to follow up on Councillor Peacock's question. So looking at how well we're working alongside our NHS colleagues and the ICB and getting that funding in that joint way, is there any capacity, do you think, in the future of, as you say, you've got a new dementia coordinator, about getting them to sort of have that area like one of the hubs that's already up and running in Wood Green or Tottenham or wherever it is, getting that sort of that support in a little bit more sort of focused way in one area, so that people know that there's an, you know, if they know that somebody's working out of a specific hub, then it tends to sort of attract other, you know, support and services, and it becomes a little bit more known to members of the public. I think sometimes we have brilliant services, but it's just getting those people to know where to go to access them. Yeah. And it's just having a base. And I'm just wondering with our NHS colleagues, because they do have hubs and there are new things that we're always looking to develop alongside the NHS. And it's just an area that I'm just wondering if we could just maybe enhance that a little bit more and pull in some funding, because we do have areas of deprivation, which I think we should be sort of challenging the NCL and saying, look, in these areas, we do need extra support and we do need extra funding, always looking to bring in funding and how about it. So I'm just wondering if that's something that could be.
I take him swimming on a Thursday morning, but it's in Barnet. And it's swimming for people with dementia and their carers. And it's quite interesting that we need more people to use that facility. The other one is at Alexandra Palace. So we go there on a Thursday afternoon and we go to Park Theatre on a Wednesday morning. So Wednesday and Thursdays, my days fully booked with people with dementia, and they're all different types of dementia. I wasn't aware of that. And some is really, really sad when you see these people coming in, really sad.
Thanks, Sheila. Yeah, you just there giving us a little run through of all the different services. And it's great that you go out and you've experienced them and you see them. It's a good question. Part of me thinks that's something I'd like to wrap into a localities conversation about what we could have available. You know, I'll be there if you do a JOSC on dementia services in NCL. You know, I'll come and I'd be really interested in conversation about how we feel we're meeting need, especially at the most of our most vulnerable. You know, I think we are doing a lot of really good outreach, and I do feel passionate that it is much more than just about buildings. It's about getting out, and actually we see that because we see people that do travel around the borough, but and meet others and enjoy that part of the process as well. Be they the carer or the person who has a condition and whatever that condition is. But it's a good question and it's a good challenge, and I'd like to see that bring up that conversation. And what goes for dementia goes for some of the other conditions that we see in our communities around what localities, what will that mean? Will there be a place that someone can go and, as you say, have a conversation about some of the things that are happening at home with their loved one or with themselves?
Yeah, so I was just having that space, isn't it? And then you're right, everyone then can go out, you know, and have all those different services out and the outreach, but it's just having that. And I think it's easier sometimes for people just to say, well, if you go to there on a Tuesday or, you know, and that's that first touch point. And then after that, they can then, but it's just having somewhere a little bit more concrete that other people that don't necessarily live in our world of services, it's easier for them to just go, well, it's at this place or that, you know, and then it's just making sure enough everyone gets that access to it rather than just those that are in the know get the access to it, if that makes sense. So Councillor Brennan.
So sort of building on from what Councillor Collins was saying, the slightly different angle, I was thinking because Councillor Peacock reminded me the wonderful services that they do for dementia in Alexandra Palace. Yeah. And I was thinking, and I've said this to the council before, we don't get across our services enough to residents. And I was thinking, could we make, because as you mentioned, we seem to have quite good dementia services in different places on different days throughout the council, and could we make some sort of like little flyer that we put online maybe that looks all nice, you know, dementia services?
I've asked a people to do a whole page on pensioners.
Well, yeah, that too, but that's one off.
So you'll be pleased to know that's exactly the role of the dementia coordinator. It's really looking at that borough-wide support networks for dementia. And make sure there's that awareness raising and connection. And what we plan to do, I was just reading the note from the officer, is to host a dementia in Haringey Open Day to share all the existing and new collaborations. So is that borough-wide sort of, it's almost like a call to action in terms of how do we make it, you know, we've heard about a child-friendly borough, how do we make it a dementia-friendly borough? How can we identify the resources within the communities actually supportive of, you know, people with dementia? And I think that is actually the role of the dementia coordinator, a main part of that role. So we're happy to come back to you once that person's been imposed to.
I mean, I know we mentioned when we went to the, I think it was the OSC, when we were talking, Councillor Bennett was talking about the old-fashioned way of actually putting little flyers in libraries does work.
Yeah.
And so that side I'm quite keen on, just to have the little library, people pick it up and say, oh, dementia services, there.
Yeah.
And I have to say, I feel like I have to say something. Honestly, I haven't paid these people. You're the second person today. Everyone knows I'm really passionate about better information, and I do think there's something about printed and the electronic. And the electronic's important because it's easier to update, and you can, as I said earlier, in a similar conversation, you can update it, and also someone can work with you to navigate it if you can't. But having something in print, but officers are going to think I've seeded these conversations because you're the second person today to talk about the, you know, that physical, and it's, I think it's really important, and it's part of a bigger piece of work within the council, which is about our website, and is just about how we communicate better with people and how we tell them about all the services, NHS, local authority, and also all the voluntary sector ones, and all the things and groups that are going on that are more informal. So yes, absolutely. Thank you, Kathleen. I'll give you a tenner later.
Maybe these posters on buses that you change, you know, like sometimes we have Harrogate posters on different things. Maybe we should have a set programme that we advertise, we have constantly going, the different service posted up, you know.
There are notes being taken.
Everywhere.
Okay, I've got one more question to ask, and this is so this may need this might not be for this scrutiny, and it might just be a written response. It was about, I got an email from a resident today about information that they had at the Carers Forum, and I think this is going back to communication. And they came away from a presentation that they've been given with an understanding that some people with disabilities, where the parents or the carers were on income support, were being charged quite a bit on a community care charge by the commissioning unit. And it seemed to be that they were saying that the council were asking money back from people who were already on benefits. And it didn't sound like it was what was being asked at the Carers Forum. It seemed like an odd thing for officers to be going and asking and saying to people who are caring for people with disabilities, we're actually charging more, so we want more money back from you. But I'm just thought I'd flag that up, and it's a question that might need to be taken.
Was at that forum. So
Excellent. Well, I had a feeling she might be, but I wasn't going to sort of say, just in case, you know, I'm sure there's an explanation to this, Vicky. It's just that I was asked to get some clarity on what this was about. Thank you.
Thank you very much, Chair. And I can confirm that that was not said. So I think it's a communication error. So what we did do is, when I first went to the first Carers Forum, I agreed with them because there was lots of questions around charging. So I agreed that we would get brokerage in the room and let them put those questions to brokerage, go through the process and really outline it and the pathway. And that's what they did. They came in, I was sat there. Nobody pays more than they're eligible to pay. Absolutely not. And anybody on benefits would not be expected to pay the amount that was in the email. Everybody gets an individual financial assessment. And what we did do at that meeting is I agreed that once a month I'd set up a surgery within the Winkfield Centre, so people with learning disabilities, their families, carers can go and be supported with the process to remove that anxiety that people experience when coming through multiple forms and the unknown, really. So it was a more of a supportive offer. The information that's been fed back is not correct, and I'm more than happy to go back to that individual and have a further conversation. And like I said, we set up the surgeries so that we can really get underneath and support everybody who is struggling with that area of administration, really. So thank you.
Okay, so it was to do with this online financial assessment portal. Is that the issue?
Yeah, that's what we did. We went through it. And people were worried about it. So I said, don't worry, we're going to do something different for you. We're going to get these guys to come down once a month. You can have a drop-in centre. Let's support you with the process. So there's no charge of that level, unless somebody genuinely is. But that's above and beyond what the maximum amount you could pay anyway. So it's wrong information.
Okay, I think sometimes it's that community is that you sometimes don't hear what you think somebody's hearing, and other people are hearing something different. So I think it's just around that communication.
Quite stressful.
Yeah.
And the idea of tech and a portal, well, I think that's quite stressful. So
they've got
perhaps
that.
we'll make sure we get a written response anyway on that, because it sounds like quite a complex issue.
Yes, it was.
And that you have a written.
That would be great.
And it sounds like Vicky and the team can pick up in surgery.
On those surgeries. I think that'd be very reassuring, I think, for people, because I'm sure they're going to come to you. I don't think I'm going to need to forward anybody. I think they'll definitely be turning up. Okay, so that's all the questions I had on my list. Anything else for Councillor Snebs? No. Okay, so I think we've made some recommendations based on the Q&A session today around the gambling and the violence against women and girls. Anything else that you'd like to add? Right.
A few written responses.
And we've got some written responses coming back. So thank you very much for your time this evening. I will just keep members, the committee members still in the room, because we still have to discuss our project that we are going to be doing. But for everybody else, all the officers, thank you very much for coming along this evening, and safe journey home. Be on Tuesday.
Thank you. Good night, everybody. Good night.
Thank you.
Bye.
Has been diagnosed with dementia.
Gosh, that's not good, is it?
Remember Jean Brown? She was in Mold Park.
No, sorry.
Yeah, she's been diagnosed.
So, Dominic, would you like to go through the project for the panel?
Yes, or shall I just, there's two parts. There's the council calendar for next year and then the projects as well. So shall I?
Sorry, the what, say?
The work programme for the next year for 23-24.
Yeah.
So I've seen a final draft of the council calendar for 23-24, and our first meeting is on 22nd of June. We don't currently have anything scheduled for that meeting, so we'll need probably to finalise our request for reports by the end of April.
Okay.
There's also then meetings in September, November, December, which is the budget, and then February. So in September, we've got scheduled at the moment, or penciled in, the update on the response to the Living Through Lockdown report. That was the Joint Partnership Board report.
Yeah.
And then in November, we have standing items of the Safeguarding Adults Board annual report and the CQC update. We've also got an update report on the Adult Social Care Commissioning Scrutiny review that we did on co-production. So there's quite a lot scheduled for November already. And then to be confirmed, we were going to have an update on the Osborne Grove nursing home project. So that could go in. We can talk to officers about when's the most appropriate time to schedule that. So those are the things we've got at the moment. But obviously suggestions for other items, and we can circulate all this, and obviously some details from the feedback from the Scrutiny Cafe earlier in this municipal years, because that's had some suggestions as well. But we just need to update that work programme over the next sort of 6 weeks or so, really. And then secondly, on the scrutiny review, so we had the evidence session recently where we had all the various heads of team from the adult social care. Review on access to adult social care, and at that session it was determined that we would focus on discharge from hospital, including barriers to discharge relating to sheltered housing. So that project, so because we've now got a sort of 3-month gap between this meeting and then our next meeting in June, we'll put some dates in the diary this week for evidence sessions on that, which will be sort of taking place over the next few weeks, and then we'll finalise that project. And then the second scrutiny project, which we are looking to do from September, would focus on digitalisation and communications with residents. And there was one other thing which came out of that meeting, which was we wanted to look at the workforce strategy, including the recruitment of new social workers. So that's another item that we can add as an individual agenda item to our work programme for the next year. So that's where we are with those things. Summarising your pack in the document at the end of the agenda pack.
So I think I sort of put an email together about where we were particularly looking at within the project. Do you want to just quickly?
Yeah, I've got that here. Actually. Yeah, so the specific evidence sessions. So there was
Empower.
So there was that was a separate email,
Yeah.
but that's the piece of work that I think you referred to as an external consultant looking at some of their work. So they had conducted some reviews on some of these issues already. So we can have a look at that in some detail. Then the other things you noted down there was housing officers in terms of homes fit for discharge. That's repairs being done. AIDS and adaptation services, sheltered housing leaders coordinating with discharge from hospital. Discharge coordinator from Whittington and North Mid to see their perspective on delays and health officer. So that was one. And then there was something about support teams to facilitate care for people within their own home. So basically it's a whole range of issues that we're looking at in terms of the discharge issues. And we discussed some of that during the meeting today, of course, but we're going into that in detail so we can make some recommendations sort of May, June sort of time.
Okay, is everyone happy with that?
Did you mention the modern slavery? This thing we've got written down, modern slavery, including input from the communities in 2020.
Oh, I didn't specifically because they haven't been scheduled, but there are some in the pack. There are some suggested items, things that have come up in previous meetings that we the panel's expressed an interest in looking
Quite
into.
an interesting idea, and I think that we might find that there's some in Haringey. I have a feeling.
So which one are you?
The thing, November 20th, the modern slavery issues to follow up include modern slavery, including input from the Community Safety Partnership.
But that's going to the safeguarding adults board, isn't it? We've asked for a very specific look into that. So they're already going to be doing a piece of work on that for us.
Okay, yeah.
That was our recommendation to them.
That's fine.
Yeah, so yeah, no, we specifically requested that the safeguarding board look into this because we were really concerned. Remember, the numbers didn't add up in the report. So we asked them to do a very specific piece of work on that.
And just on the evidence sessions, just wanted to check with everybody that I was aiming at putting in some sessions for early evening, sort of 5:30, 6 o'clock starts.
What's your timings?
Because I know that when we've done this during office hours, because we had the last session we had just by necessity had to do it about during office hours, and a couple of people couldn't attend. So I guess we're looking at early evenings to try and avoid clashes with people's existing evening meetings. Well, sure, but I mean, this is basically the opportunity to tell me any days to avoid and that sort of thing. And also, are we happy to do these on Teams, or do we want some in-person sessions? If we have external people, sometimes it's easier to do it on Teams to avoid them having to travel. But I mean, I guess it's just sort of getting a sense from the panel about what their preferences are.
I found when we did the Violence Against Women and Girls session at OSC, it was really good having people in the room. So I think it depends on who we're speaking to.
Yeah.
And you're right. If someone's, we're asking someone from Manchester, then obviously we'll do it on Teams. But if they're local, then it would be, and it was, not too late, then it'd be quite nice to sort of, because I think often what works really well is when you get a couple of different people in the room and they sort of say something and then the other one goes, oh, I didn't, and then we get a much more interactive approach, rather than if you're on Teams, everyone sits there in silence until you ask them to speak. There's not quite that same level of engagement.
Just my
just let Anna.
No, from my perspective, I work full time, so the later the better, because it's becoming almost a weekly occurrence that we're having council meetings during work hours, and it's very difficult to explain to our employers that we need to sometimes take up to like 5 hours a week out of our working week.
Yeah, no, absolutely.
Due to council meetings, it's just.
And it's so things like 6 o'clock starts. Is that too early, or is it like are we?
I mean, I think I can work from home and get here by 6. I won't be able to go to the office.
Okay, but where we can, if there are times when there's not, because I think some parts in April there's not that many council meetings anyway, so we might be able to do some ones that are more like tonight, of 6 or 7 o'clock. So if that's sort of.
Anyone else?
Even that is difficult out of work.
Yeah.
And also, if you can be flexible.
Yeah.
So you can still come in person, you can still meet by Teams, that would work as well.
Have we got the capacity? Because you said before when we were I know we've tried to do this, haven't we? And then you said we couldn't do a hybrid one.
Well, we have got more. We can't do it with this sort of setup normally, but we are doing have access to a few more rooms that have got screens in the rooms, a bit like we did for the session with the initial session that we did for this panel for the adult social care. We had some people joined on Teams, and we had people in the room. So there are a few facilities around. We've gradually sort of added them to our list. So we'll try to do that where possible.
Yeah. Okay.
Sometimes Teams works if you've got one meeting following another one.
Yeah, exactly. So it's I think it depends, doesn't it, on how squished the meetings are together. And I completely agree with you. Otherwise, it's impossible.
Does
Okay.
it make a difference for our attendance record if we attend in person or virtually?
For meetings like this, it does. Yeah. I think I'm not sure evidence sessions are
Not for
counted. I don't think they're included in your attendance figures. But yeah, I think for the regular meetings, full meetings like this, it does make a difference. Yeah.
And I think so if we look to see how we're going to group these people, because you might think, well, actually, if there's 3 or 4 different speakers in, I'll come in, and I'll just do that. But if there's one person and it's half an hour session, then I'll come on Teams. And I think for me, that makes a difference as well. If you feel like, oh, they're going to get a lot out of it, then it'll be easier. Okay, so Dominic, can you see what you can do about
So
getting
an update this week, and
Right.
and that with the schedule for next year as well.
Right.
To get some-
Get them in as soon as possible, then other people can't grab those.
Yes.
Yeah.
That's lots. The September one's the 11th of September, isn't it? The meeting in September.
When was it? 18.
I thought you said the 11th. Or was that Joss?
That was probably the JOSC.
Ah,
I'll
okay.
send you the call list.
Would you? That's, yeah, okay.
Because the ones for this panel, I've seen the final version literally this afternoon.
So that might be the 18th. Okay. Lovely, brilliant. Okay, well, thank you very much. So obviously, if you've got any ideas about the June meeting that's on the list that we haven't added, but also you've got the aids and adaptations, which Vicky said might be able to come back sooner. And if there's anything else you particularly want to be put in, please let us know. We'll just have a round robin email and just people put ideas in. And we'll put those on. Dominic, could you circulate anything from the Scrutiny Cafe that you think we haven't picked up as a theme?
Yeah.
And that might be something we could look in for June as well. That'd be great. Thank you.
Yeah, I'll do it.
And was it Jessica Bradbury?
Yes.
I've sent you an email with her
Yeah.
details.
Great. Okay. Well, thank you, everyone. That's
Thank
the
you so much.
end of the meeting. Thank you so much.
Thank you.
Thank you.
Luckily, my other meeting finished a bit early and I was able to get there.
That's fine.